I hope everyone is comfortable with recording.
Yeah, very fine. No problems. That's a must.
No problems at all.
If anyone isn't, please do take your, if you can switch your video off if you don't want to be recorded, please.
Good evening, everyone. Here Imran Abbas. Again, we are live, not only from Dubai, now from all over the world. Just now, we are live from Dubai, from Singapore, from UK, from US, from Spain, India, Pakistan, Mexico, and Germany, and all other cities. So it is great honor. So we have started this series of MGB, OAGB about 6 months ago with Professor Robert Rutledge. And so end of this series was with Professor Carbajo. And today is a dream day of MGB, OAGB session. In my opinion, this is great opportunity for all of us to know more about MGB, OAGB. We have tried our best to select main questions, and also we will have panelists, expert of MGB, OAGB, and you will have this opportunity to know more about this. So in this session, we will have 4 moderators: Professor Ariel Ortiz from US, Professor Asim Shabbir from Singapore, Dr. Tansir Asghar from Islamabad, Pakistan, and myself, Imran Abbas from Dubai. So we have these sessions, and our sessions will be chaired with Dr. Amir Khan from UK. Dr. Amir Khan is also Educational Director of Global Laparoscopy and Robotics. And also Professor Arun Prasad is President of MGB, OAGB, International this Bariatric Club, and he will be live from India. We will have 9 panelists. So these 9 panelists we have divided in 4 groups. So MGB original technique group will be Professor Robert Rutledge and Professor Kolar. And OAGB group will be Professor Carbajo and Professor Enrique from Mexico. And hybrid, so they are using some technique of MGB and some OAGB. There will be 3 experts: Professor Helmut Billy from US, Laurent Layani from UAE, and so third one, Nasir Sakran from Israel. So these 3 persons will be hybrid, and we will have also 2 persons so these scholars, and also we can ask publishers, Professor Chetan Parmar and Kamal Mahavar from UK. So these 9 panelists will help us, so also will guide us so about these questions. So now this is the time. So Professor Ariel Ortiz, over to you, sir.
Thank you so much, Imran. It's a pleasure to be with everyone today. This is a great event, I love the series of questions that we are posing our expert panels. As you said, we have divided, you have intelligently divided our experts into the MGB, OAGB, into the hybrid group, and of course our scholars that are going to tell us what's published out there. But before we go there, I want to introduce the chairman of our session, Dr. Amir Khan, who is going to talk about the objectives of this course. It's extremely important to communicate what we're trying to do. These are not just a series of questions. Remember, at the end of the day, we want to standardize approaches. We want to take them to the next level of understanding so it will benefit our patients. So I will directly go into the introduction. Dr. Amir Khan is the Education Director of GLR, and of course he has designed all this series with Imran. But apart from that, he is Senior Consultant, Division of General Surgery, Upper Gastrointestinal Surgery, Department of Surgery, National University Hospital. Hospital. He's also Senior Consultant, Division of Surgical Oncology, National University Cancer Institute in Singapore. He's Senior Consultant in Alexandra Hospital and Deputy Head Department of Surgery and National University Hospital and Director for Center for Obesity Management and Surgery, COMS, National University Hospital. So it's my great pleasure and honor to present Dr. Amit Khan, who will tell us about the objectives of this session.
Great. Thanks very much, Ariel, for kind introduction. Just to clarify a couple of things. I'm from UK. I think a part of that introduction, it was also about Asim Shabir, who is from Singapore, who is involved in oncology and bariatric from there. So we'll come back to that bit of later on. First of all, on behalf of GLR, I'd like to welcome you all, because to be honest, when this was all started, it could not have been possible if we did not have cooperation from experts. And it's been a great opportunity, and it gives me a huge opportunity to welcome you all. Today we got, I think, I would say, the panelists here. These are the people who are experts in their field, and I'm hoping to help us to understand this procedure more. Imran has been running these sessions, individual interviews he's done 22 sessions of it, which has covered most of the aspects of it. But today is the plan that we go through all those questions which have come back to us from the audience, so that we can help people to understand and at least standardize the procedures what they're doing. If you see, the reason we started MGB is there are multiple procedures in bariatric surgery, as we all know. But the procedure which has been harshly criticized or harshly scrutinized is MGB. MGB has been scrutinized quite a lot over the years. In 1997, I think Rutledge was the first one to perform the MGB, and has done thousands since then. The reason this procedure has been so much scrutinized is because of the experience of surgeons with Billroth 2 gastrectomy, and people have been reluctant to take this on. But since Rutledge is starting this procedure, there are thousands of these procedures have been done. I was looking through some literature. At present in Asia, 15% of bariatric procedures are MGB, more than 15%. So there's a huge number of these procedures being followed. Carbaggio published his results in 2005 to show the efficacy and effect and also safety of this procedure. Until then, there have been lots of different arguments about this procedure. The original MGB was started by Rutledge. Then Carbaggio's group, they came up with side-to-side anastomosis rather than end-to-side anastomosis, and it became OAGB, one anastomosis gastric bypass. So today we're going to have an opportunity to listen from the speakers themselves and understand what were the reasons of different issues related to these procedures and how they've got over it, and also to understand the standardization of this procedure. This procedure is so widely being used that people have actually mixed up a lot of things which have come from MGB and OAGB, and everyone is doing it in a different way. But I think in order to get the best results going forward and to minimize problems, we need to understand what the experts say about it. So hopefully this session today is going to sum up all what you've heard so far in the last 22 sessions, but also answers the questions which have specifically been asked by our audiences. So I'm sure by the end of the day, we should be in a position to understand all that. The way this program has been designed today is that there are 4 parts of it, and each moderator is going to take time. So what I'll do is I'll let Ariel and Imran explain that further to you. Please enjoy it, make the best of it. I'm sure there will be questions afterwards, which we'll take on later on as well. Thanks very much, Ariel. Back to you.
Thank you so much, Professor Khan. All right, so let's start off with this session, and it's going to be, I wanted to let everybody know that we're going to try to be very punctual. So we've got the following 50 minutes to discuss this. at the leisure of the expert panel. And for starters, I have a series of questions that I myself am going to pose to the panel. And as we said, we have our MGB experts, our OAGB experts, our hybrids, and our scholars. And let me start off by posing our first question. When and why did you start the MGB? And that question obviously goes to Professor Rutledge. Professor Rutledge, it's a great pleasure to have you with us today.
Good morning. I apologize. My internet here in San Diego has been a little bit of a problem, but I will tell you if you ask a brief story of the first MGB, is that acceptable?
Sir,
Exactly.
Please, sir.
Okay. So for 20 years, I was a trauma surgeon. And when I was hired as a new surgeon at my university in North Carolina, my chief said, Dr. Rutledge, we are happy to have you join us. We'd also like you to help with bariatric surgery. This was in 1980. So that means I'm old. And he said, we would like you to help with bariatric surgery. And I said, sir, I'm not interested in bariatric surgery. I'm a trauma surgeon, a specialist in critical care. And he said, do you want the job? And I said, well, now that you put it that way, I've always been interested in bariatric surgery. But of course, then we were still doing jejunal ileal bypass, open Roux-en-Y, something called a vertical banded gastroplasty. And those were really not to be critical, but difficult procedures. And so laparoscopic gallbladder became an interest. And so I became one of the early laparoscopic Roux-en-Y surgeons. And just to remind you, we were told you must take out the gallbladder. It must be retrogastric and retrocolic. And we actually pulled an EEA anvil through the esophagus. So it was a difficult procedure for me. And but I was doing that operation with some trepidation and difficulty when one night I was on trauma call and one of the patients who came to me was a drug dealer who was shot 6 times in the abdomen with a .357 Magnum. I took him to the operating room and resected the distal stomach, the pancreas, distal pancreas, and the spleen. And I reconstructed him with a standard general surgical procedure, which is an anticolic Billroth 2 gastrojejunostomy, as well as the rest of it. The next morning at 9 a.m., I had a laparoscopic Roux-en-Y scheduled. And I recalled the night before that there was a standard procedure, which is the Billroth 2. And given the difficulty, the complications, and the criticism of laparoscopic Roux-en-Y, I did what was subsequently called the mini gastric bypass, and the patient did well. And instead of taking hours and hours, it took me only a short period of time. I did about 60 cases there as a trauma surgeon and professor of surgery. And because of their excellent results, I actually quit my job at the University of North Carolina. And now 23 years later, it seems like some version of the MGB might be a reasonably good operation.
And one question, Professor Rutledge, why did you name it the mini gastric bypass?
Well, what I told my patients for a year or two was this was a callus gastroplasty, a standard general surgical procedure with an anticolic Billroth 2 gastrojejunostomy. They didn't quite understand that. And then at the time, you may not remember this, you're much younger than I am. And at the time, it was all these new operations were called minimally invasive. So it was titled the mini gastric bypass. It was just a minimally invasive gastric bypass and shortened ultimately to MGB.
Wonderful. I'm going to ask Professor Cuellar just to add a little bit to this story because, well, you're definitely considered in our MGB group. Do you have anything to add from a historical standpoint?
See, with mini gastric bypass, you know, when you are performing bariatric surgery in Indian scenario, here most of our patients are private. They are paying from the pocket. And their expectations are way too high. So I started my practice with the Roux-en-Y, but looking into the results, you know, when we completed 45 Roux-en-Ys, me and my colleague, Dr. Manchanda, were sitting in the surgeon's room. And we were discussing like Dr. Manchanda, now it's time for leak because, you know, if we look into the publications in Roux-en-Y, generally the incidence of leak is to the tune of 1 to 2%. But we are working in a community setup outside the city on the outskirts. So it's a small setup now totally focused to bariatric surgery. So we were thinking like we could not handle, you know, if there is a leak in our Punjabi scenario, in Indian scenario, if you make the patient stay in the hospital, in the ICU for like 15 days, 20 days, or even more, then maybe, you know, majority of the patients are not going to pay any further whatsoever package has been decided. It's a kind of, you know, walking on a wire doing bariatric surgery here in this part of India. So I was in search of a safer procedure and a more efficacious procedure. And I came across Rutledge's videos on YouTube. And then I contacted him and I requested him to, you know, allow me to come to his place, which he agreed to. And when I went back there and looked at his patients, which I compared to my previous training at 12 Oaks Medical Center, Houston, Texas. And there was another one, Cypress Fairbanks Medical Center, Houston, Texas. I observed Roux-en-Y's there and then did my experience with Roux-en-Y. So when I looked at Rutledge's patients, there was no look back after that. He had a few surgeons, gynecologists, a few of his other colleagues, operation theater assistants. 4 of the assistants standing in the operation theater, they were like 10 years down, 8 years down. And even his own wife, Trish, I sat with her, she was 15 years down, the procedure. So I could see that this procedure will work in Punjab because here we have patients who would like to eat chapati. So the minimum volume, you know, we need about 200, 300 ml minimum volume. They have to have these carbs. So I looked at the happiness score, results, leak rate, revision, revisability, all these facilities, and there was no look back. I started with this, then every year I would go to the national conference and I was asked this question, Kular, are you still doing MGB? Because there was so much of criticism. So then I will keep standing in one corner and quietly then I'll say, yes, sir, I'm still doing it. Why? Because my patients are happy. So in Indian system, if your patients are happy, you are happy. And now we see all the publications coming from rest of the world. Things are looking quite good. Yeah.
And we definitely have our experts that are our scholars who are going to be discussing specifically that in the next number of questions. I appreciate your contribution to this, Professor Kular, and I'm going to ask the same question. When and why did you start? And since we are going to talk about the OAGB, I want to talk to Professor Luque de Leon to ask him exactly that question. Enrique, do we have you with us today?
I'm here.
Thank you so much.
Hello, good morning to all. So the story is I was trained at the Mayo Clinic in Rochester. I did a fellowship there, and the professor that was doing bariatrics there was Michael Sarr. He was doing the Roux-en-Y gastric bypass open. There was not laparoscopy at the time. Came back to Mexico and did some Roux-en-Y gastric bypass open, then some laparoscopic. Met Miguel Carbajo, actually brought him to Mexico in the year 2005 for meetings. And then in 2009, I decided to work with him for some months, which I did. And the rest is history, because we've managed to have a very close, not only personal but professional relationship. I have no reason really to go back to the Roux-en-Y gastric bypass after the results I've seen with the OAGB. this differentiation of OAGB, MGB really has come afterwards, and I think we're going to be talking about this through this morning for us and evening for you guys. But this is really the story. One of the really things I was skeptical about because of what everyone was saying was bile reflux. So when I was with Miguel in Spain, he can recall that when he left the room, to go somewhere, and I was with a patient, I would always ask him, do you really don't have any reflux? And to my surprise, no patient had any reflux. So that was the as you know, the pinpoint that many patients were, or many surgeons were arguing or having as an argument against either one of these operations, MGB or OAGB. So that really took my skepticism, at least as far as bile reflux was. I'm surprised that 10 years or more after this, we're still having this skepticism on bile reflux when I think it's a dealt issue. And maybe we will have some time, but I think the most controversial issue, either for Roux-en-Y, for MGB or OAGB, is the small bowel length. This is the most controversial issue.
Professor Luca, thank you for that brief summary. And following that specific comment you just made, just coincides with my question, my second question, which talks about the technique and how has it evolved over time. So we need our speakers to share their changes, why they have happened, and what changes they expect in the outcomes. And for that, I also have Professor Imran, who has a series of videos that he will play appropriately.
Now I think is impressed.
Sir, can you see?
And it's coming soon. In short, I describe the technique change of the past 20 years in my experience. Can you see the slide?
Yeah, sir, we can see.
Okay, so you can see I start from the first, I divide the 20 years into 4-5 years period. So at the first 5 years period, I doing the mini bypass according to the technique of Lutridge. So it's an anterior anastomosis and fixed 200 centimeter BP limb. And in this period, I do randomized trial using this technique comparing to the Roux-en-Y, but it's a retrogastric, retrocolic, quite different technique as now. But then in the next 5 years, you can see we start to doing sleep gastrectomy. So we learn something from sleep. So at this period, I use the 36 French bougie to calibrate the tube because I think the procedure need to standardize. And we also realize the importance of restriction on bariatric surgery. Without restriction, you will almost fail in every bariatric procedure. And also, we met some low BMI patients in Asia. So we had some malnutrition, so we decreased the BP limb in low BMI patients. But at the same time, we have very super mobility, 50, 60, 70 BMI. So if you use a fixed procedure for all these different BMI, it's not a reasonable choice, right? So we start to tailor our BP limb according to the BMI. This is the second stage. Then I think now we move the third 5 years period. In this period, we learn something from sleep because there is a leak 1% around the EC junction area. When we go into sleep, the leak increased to 9%. So we start to reinforcement the gastric tube. By that technique, we reduce the leakage from sleeve almost to zero. So we also start to reinforce the tube since 2011. And also we change anastomosis to posterior wall because we think it's more physiology. Because you put on anterior wall, there's a tendency to draw anastomosis to left side. Sometimes we go inside again, revision surgery, we can see the old tube going to the left side. So we change it to posterior wall. And also we take the technique of one anastomosis, we anchor in the efferent loop, take it higher in hope to prevent some bioreflex. And also we fix the gastroanastomosis to entrance. So this is the most of a change in 5-year period. In the recent 5 years, actually, we had some patient had malnutrition. When we go inside, actually they are short bowel and they are too short common channel. So we start to count the whole bowel and decide we need to preserve for the Asian. We need to preserve at least 4 meters for our Asian because the protein intake is not so satisfactory in Asian population. So, or we fix on 30 to 40% BP limb of the whole small bowel. By this technique, we can avoid most of the malnutrition after this procedure. So you can see at the first period, we start from the MGB, but now actually we're going to maybe single osmosis or one osmosis, what's your name? But it's quite different technique now. So you can see by the photograph, this is the MGB, then start to the OAGB, and most different is change to a posterior wall and anchoring the two sides. By upper GI series, you can see at the old time, it's a loop anastomosis. So the foot coming down, they go to the efferent, also go to the efferent. But I think if you go to the efferent too much, you lost the effect of BP limb. So when we anchoring the efferent loop higher, you can see it's like a Roux-en-Y gantry bypass. You can only see one loop going to the efferent loop, making you more comfortable. But now I want to call my technique called OAGB in situ. What that means is when you have a long tube cut from the entrance, then you fix it back. You see it look like a normal anatomy of the stomach tube here. So it will not change. So he will stay in here. And anastomosis on posterior wall, so everything goes smooth to the distal. And you can see this is anchoring loop is here. So basically you prevent the full string go to the efferent loop. And the gantry tube will stay from where he comes, not from the entrance lesser curvature side. So I want to call this figure OAGB in situ. Yes, so.
And I will repeat it again and again. We have the key point to prevent GERD and cancer in MGB is just to perform the procedure properly. This means a long calibrated gastric tube, which should be more than 12 centimeters long. And the starting point is the antrum, not the angulus or the sura. No, it's the starting point is the antrum. And a wide anastomosis to have a good drainage of the low pressure gastric sleeve. This I will repeat again and again. These are the key points, what we have learned. This picture is from a publication from Mario Musella. Everybody knows him from Naples, from University Federico II, and shows the differences between the old Masons loop bypass. This name is very common still in Germany. On the right side, the mirror 2. And on the left side, the MGB OAGB. And I tell you, this drawing shows not the perfect MGB and OAGB. The gastric sleeve is too short. And the distance what you have between the esophagus and the anastomosis, it's maybe 5 or 6 centimeters. This way should be here to have it longer, and the anastomosis should be here. The anastomosis should be below the transverse colon, very, very down and far away from the esophagus. This is one of the key points. And you saw another mistake. If you're looking above, you see, you know that Robert Rogers said, "Oh, it doesn't matter. You can go just up and not." Yeah, it's correct. Not too close to the esophagus, but left fundus, a large fundus in place. What we have, especially in this area, after, for example, after sleep or after gastric banding, this causes also problems because you have too much acid production. And then you have the problem of ulcerations. So the sleeve should be done very probably long and narrow and a wide anastomosis. Not this is just in contrast to Roux-en-Y gastric bypass. Roux-en-Y, you should have a small anastomosis to have so-called restriction. This is not a way here. You need a good passage. And if the bile comes always into this area, but if it's wide, it goes always rapidly down, and you have no bile gastritis in this area. So look, if you fix it before, you see this is a very, very good place. You see the transverse colon, and the anastomosis should be below. This is from a publication, and a long wide anastomosis, which is 6 centimeter long device. This is the best option to prevent all the problems. Thing is also the small anastomosis. This is a bile gastritis on the left side. Red inflammation caused by bile, and it's very small. It's not a stenotic by inflammation. It's primarily too small, and the bile comes in, and the bile will not go easily out. This is what we learn. If you have the same extremely wide anastomosis, like in this case, it's also the MGB. Yeah, and maybe you can see also the bile is carried, but there's no bile in a gastric pouch. You need a wide anastomosis.
Perfect. Thank you so much, Imran. And thank you, Professor Lee and Professor Weiner. It's great to hear from them. And I'm going to pose the same question to our expert panel. What have been the changes that you have adopted, and what are the expected outcomes or resolutions that you expect from those changes? And I'm going to leave it open to all our expert panel, and whoever wants to start.
Well, I'll jump in since I live in the country that has caused the most, over assessment of the MGB and has limited its adoption. It's a very lonely course to be one of the only surgeons in the Western United States routinely offering MGB. And my introduction to MGB occurred overseas, where I will never forget the moment that I thought, this is a very good operation and everyone in the US has been lying to me. And most of the criticisms come from people who have never done one, never taken care of one, and yet are informing from very powerful positions in our country's medical societies that this is an operation not to be done. So I've always been perfectly happy to stand out in the middle of traffic and hope I don't get hit by a bus in the United States when I see something that I think benefits my patients. And we went ahead starting with revisions, which are not quite the perfect procedure to begin your MGB career, but it's quite difficult in the United States to be depending only on cash paying patients to do primary MGBs. And it quickly became apparent to me that the length of the MGB tube needs to be as long as you can safely make it. You really do need to identify the crow's foot, and you really need to keep it at 12 centimeters or longer for an optimal operation. This became very apparent to me, and I saw many surgeons, even overseas, dividing sleeves above the crow's foot, kind of doing what was easy. And as I perfected that technique to be able to revise sleeve into a much better operation for these patients, we were able to grow our primary procedures confidently, because again, when you're standing out in the middle of traffic, there's certainly a bus driver trying to steer his way into hitting you off the MGB podium. But our success has been quite profound and I'm very happy with it, to the point that I have told my colleagues I would, if it was approved by insurance, I would probably never do a Roux-en-Y gastric bypass again. I would do them all at MGB. And I'm sure that's had some negative impact on my forward motion in the United States among my peers, but I'm happy to do so because it's a very good operation. I really do depend on learning from all of my colleagues overseas and picking up pieces on how I'm going to optimize the operation best in my practice.
Thank you, Helmuth. Yes, it is a lonely place on this neck of the woods. Let me ask the rest of the panel their thoughts on technique.
Should I say something?
Please, Professor.
See, originally I started with Roux-en-Y, so I was quite skeptical about the MGB, the kind of outlet which Dr. Rutledge was recommending, the gastric tube diameter. So I tried everything which can be done to bring a change, making a tight outlet with hand like 1.5 centimeters, 2 centimeters, then with a 3 centimeter cartridge. So then I have tried making tight gastric tube, and I have tried trimming the GE junction all through, like the way we do in gastric sleeve, and then keeping a 1 centimeter, 2 centimeter cuff. So we are following our patients closely, and we have a lot of data which we keep comparing in our softwares, because not primarily to make the publications, but primarily to get the feedback from my patients and see what better I can do for them. And after these 16 years, let me tell you very clearly that what I understand from MGB is that it's just an extension to the esophagus, so which delivers the food right away into the loop without any kind of obstruction, mechanical obstruction on the way. So whatever restriction is coming from the jejunum, the filling of the jejunum. So it's a more or less kind of functional restriction rather than a mechanical obstruction. So in the long run, we see patients doing much better with wide outlet and appropriate size gastric tube, which should be loose, keeping 1 centimeter cuff at the GE junction. Touch wood, we have not seen a leak now from last more than 8 years. And another thing, keeping the gastrojejunostomy area vascular. If you see it all red, the incidence of ulcers is becoming like almost like, I cannot say it's zero, but it's very minimal, even less than what we find in, general surgery with all the gastrojejunostomies put together. So I believe vascularity of the gastrojejunostomy, wide gastrojejunostomy, wide bore gastric tube, and a little cuff of 1 centimeter at the GE junction makes my patients happy in the long run too. Yeah. And then we have changed the length of the bypass and everything. So, and altering the length, trailing the length. I know this question is going to come later, so we'll discuss this later on. Yeah. Thank you very much.
Wonderful. Thank you so much, Professor Kular. I want to ask our scholars, and I want to go to Professor Chetan Parmar and ask him what the literature describes.
Hello, everyone, and thank you again. And it's a pleasure to be here with all esteemed colleagues and familiar faces. I think, as we know, when Rutledge first published his series of 1,200 plus patients, and then slowly, and those, again, as Helmut was saying, those were lonely articles. And if you look now, and I think if you go back and visit obesity surgery volumes in the last few years, I think OAGB MGB would be the number one if it comes to percentages wise articles in those. So yes, I think there is a lot of literature out there. Again, the last systematic review which we published, which when I say recent is, it is about 2-3 years ago, was around 13,000 patients. And as we have heard from the panel, the weight loss, comorbidity outcomes, and all have been excellent. Even I think it would not be right if we don't talk of the Omega trial here, just to add a bit of spice and controversy to it as well. I think there had been a lot of negative talk about the Omega trial when it come out. But then if you actually look into detail, it concludes that OAGB is non-superior. In other words, same as Roux-en-Y. And when it comes to weight loss, it was better. When it comes to diabetes outcome as well, if you look at 2-year follow-up, it is 60% in OAGB favor compared to 38% in Roux-en-Y favor. Again, if you actually look back into the minutiae of the tables as well, you can find out that it was criticized, oh, marginal ulcer is 5%. But then if you look, actually Roux-en-Y in that series, also marginal ulcer was 7%. And the vomiting, if you put to it, was another 8%. So if you sum it up, they all were kind of similar. And again, when you look at the nutritional values as well in those, it was only the hemoglobin which was the factor. Otherwise, all nutritional value difference were statistically non-significant. And we all know then, and I think again, as Kular was just mentioning, we know that in that series, it was a standardized 200 limb for either a 35 BMI or even a 45 BMI. So those things we know contribute to hemoglobin and stuff as well. So I think that there is now enough literature out there. Also, I think 52 world experts met up under the umbrella of IFSO last year and published a Delphi consensus statement as well. So there are now a couple of consensus statements as well who have recognized that OAGB MGB is an established and a recognized bariatric procedure which should be in armamentarium of all the surgeons, I think.
Thank you, Chetan. It's great to have you with us, and your view, and not only your view, just the academic aspect of what we're seeing published in the literature. I'm going to go ahead and go with the next question that talks about endoscopy and the need for endoscopy before surgery. And it's extremely important to talk about that because we do have different protocols preoperatively. And I want to start with a contribution by Professor Mohit. Thank you, Imran. All right, we need audio. We can't hear your audio, Imran.
And I think, Adriel, you mentioned Mohit, but this is Miguel's video. So
Yes, I'm seeing that Miguel Carvajo is. But Imran, we don't have any audio.
Check
Sir, can you hear?
the possibility of new presence of Helicobacter. And endoscopy this is linked with these pathologies and also eradication of Helicobacter pylori. Eradication of Helicobacter pylori, I think, is mandatory, not only before the surgery, but after surgery, in the following controls, it's necessary perform more check the possibility of new presence of Helicobacter. And endoscopy it's mandatory also in patients that have reflux or hiatal hernia or GIR clinically presented. But in my protocol, patients totally asymptomatic, I don't know, perform systematically. But the guidelines is necessary to know that actually the IFSO guidelines
this is for isogandalysis. This indication for every kind of patient to perform and preoperative endoscopy. And in the postoperative, of course, it's mandatory in these patients that patients that have a year of previous esophagitis or suspicion of marginal ulcer or reflux, if necessary, to perform per year an endoscopy. And in our protocol, also in asymptomatic patients, every 5 years, we perform during life. During life, an endoscopy every five years.
First of all, we are happy that we have our own department for bariatric endoscopy in our own clinic. And the upper endoscopy is done by the bariatric surgeons before and after. So I have control of all my patients after sleeve and after MGB, 1 year after. And depend from the findings, I give the recommendation, everything is fine. And then I give the recommendation to have it after 7 years again. But before, you need a really good investigation and you need a Helicobacter test. And in case of infection, you need eradication. Because the remnant stomach will exist in both. And the higher risk for cancer, you have in a Roux-en-Y gastric bypass, not in the MGB. Because the duodenogastral reflux that you have before surgery and will continue also after surgery, it's very easily undisturbed in the Roux-en-Y gastric bypass. In the MGB, you have a small channel and a smaller part for bile. But this can cause chronic pain. But I remember for cases, and also in literature you find cases, we have removed the remnant stomach just for cancer, early cancer, also for chronic bile gastritis, because the patient has chronic pain. And this is absolutely necessary.
It's not routine, it's in symptomatic patients only.
And in post-op anastomosis, gastric bypass, endoscopy is routine or no? Only in
yes, we do it on a yearly basis. Yet not all the patients becoming very cooperative regarding endoscopy every 6 months or every year, because we are working on a private setup and a public governmental university. So cost is an issue. And at the same time, you cannot obligate a patient to do a routine endoscopy after the surgery. So we like to do a routine endoscopy every 6 months, every year, every 2 years. Yet we have a problem in the discipline of patients after surgery to do this endoscopy and to push them to do the endoscopy every year.
Test, we do a breath test, and if on a breath test the patient comes H. pylori positive, we treat the patient post-operatively, but it's not a contraindication to one anastomosis in our series. If a breath test is positive, we treat the patient post-operatively for H. pylori, but we offer a mini gastric bypass nevertheless.
Thank you, Imran. And thank you to all those that answered our questions. And our question goes out to our panel. And in the interest of time, I'm going to combine both questions, preoperative and postoperative endoscopy protocol, and of course, the eradication of H. pylori. Any thoughts of our expert panel? Anyone can jump in, please. Professor Goulart.
As a matter of fact, I wish I could do endoscopy in every bariatric patient of mine, whosoever comes in, may it be sleeve, gastric bypass, or mini gastric bypass. Because when we are going to deal with the internal pressures, changing the gastric tube pressure, we need to look into whether the patient has hiatus hernia or how is the stomach looking down. But not every patient agrees to the endoscopy preoperative. So what we are now doing, we have started doing intra-op endoscopy, which is coming out to be very effective. Just before the procedure, we are doing that. I learned this from Mohit. Actually, he was doing it from last, I think, 2-3 years. And post-operatively, again, we encourage almost every patient to undergo endoscopy every 1 year for the first 3 years and then every 2 years. But again, not everybody undergoes this, and majority of the symptomatic patients would definitely get the endoscopy done. And we have a long series of endoscopy reports. Now we are comparing this and publishing the data. Quite interesting things are coming up, and we are quite confident now when we are getting into the 17th year of MGB that things are really going well. But yes, we must encourage patients for endoscopy pre-op and post-op as well. Yeah.
Thank you, Professor Goulart. Professor Luque de Leon, your thoughts on pre-op, post-op endoscopy, your protocol?
Used to be only selective endoscopy in symptomatic patients, and also post-operatively only in symptomatic patients. Due to the recent evidence and the consensus conferences, I'm trying to do pre-op endoscopy in all patients, and also post-op. I don't have a recipe, you know, in terms of the year when to do it, but at least the first endoscopy, post-operative endoscopy in asymptomatic patients at 3 years after the operations. That's what I'm doing now. As far as H. pylori eradication, if there's enough time preoperatively to eradicate the H. pylori, I do it. If the operation is scheduled, you know, prior to this chance, then I give the eradication treatment 3 months after the operation.
Thank you, Professor Luque. Anyone else? Open mic. Helmet.
I can jump in. I like jumping in.
Yeah,
Since I'm an outlier, I have to consider my MGB patients a little bit more closely than I will bypass or sleeve, since there's no consensus in the US to do preoperative endoscopy, and some people argue that you don't need it for bypass and sleeve. I go ahead and do that for every mini bypass patient. I think there's several anatomic areas that I need to be cautious in. One, clearly bile reflux is the favorite target of American surgeons to criticize the operation. So I want to see in a sleeve, do I already see bile reflux coming? Because it's an indication that there may be bile already reaching the esophagus from a damaged lower esophageal sphincter. Don't forget that when we do a sleeve and we're going to convert it to an MGB, a surgeon has already operated through the angle of His and not followed the principles to keep that area wide, and the sling fibers have probably already been damaged. So I want to be able to document, is there already bile reflux with the sleeve gastrectomy? And I want to see, is there a hiatal hernia? Because there are techniques to strengthen the lower esophageal sphincter that I can do at the time of surgery if I feel it's needed. So the preoperative endoscopy is important to me. The postoperative endoscopy is also important to document, do I have any sort of reflux or outlet problem? I completely agree that the gastrojejunostomy, the diameter of the gastrojejunostomy is important in our long-term outcome. And the only way I can see that early on is to do an endoscopy. Now, in my office, I have transnasal endoscopy capability, so I can do one of these in a moment's notice. I can have a patient come in the office and be complaining enough that I go ahead and do an endoscopy that visit. On other patients, I'll schedule them in the more traditional GI lab where I have to use transoral, a bigger scope, a better endoscopy. But this evaluation and the use of endoscopy, I think that having transnasal availability, it's similar to me having a stethoscope, except it's far more useful in the field of bariatric surgery to be able to endoscope very quickly and very easily.
Thank you, Helmut. I'm going to pass it on to Chetan Parmar for his thoughts.
Thank you. So at least I can, well, let me put this first. In an ideal world where I would have the liberty of doing everything with no cost and restraints and, you know, good follow-up, I would do a pre and post-op endoscopy. But I think coming to a practical world, as we all know, it's easier said than done. Having said that, I'm one of the lucky units, maybe I can say, that our hospital has agreed that we do preoperative endoscopy for all patients going for bariatric surgery, whether it's bands, sleeves, minis, Roux-en-Y's. So I think that is one good thing. Coming to the H. pylori part, if it is patient is H. pylori positive, at least in our cohort, it is not a contraindication either for a mini gastric bypass or a Roux-en-Y gastric bypass. I know that in Far East, they have concerns that if it is H. pylori, they won't offer a bypass, but in our cohort, we are happy to offer it. Post-operatively, again, UK, we do have lots of smokers. People do use ibuprofens and naproxens and diclofenac quite generously. But having said that, we don't have any fixed protocol. Only symptomatic patients who come to us, we give them OGD. To prevent that, again, all my patients post-op go home on a 6-month course of PPI therapy anyway. And as I say, that my post-op protocol doesn't change if the patient is a sleeve, mini, or a Roux-en-Y. It's standard for all.
Thank you, Chetan. So we've got a couple of minutes to go in this session of questions, and then I will pass it on to Asim Shabir for the following questions. But my last question has to do, yes.
Why? Because you labeled me as the scholar on that, and I have to quote literature. I was just going to quote the last if so statement by Wendy Brown on the OGD and stuff. I think it's a good practice to have pre-op OGD and all, but I think they suggested that for post-op patients, every 2 to 3 years, sleeves and MGB should have OGD and not Roux-en-Y. Probably that I don't agree. I think if you have to, do it in all.
Thank you, Chetan. It's a great label, though. All right, my last question has to do with the presence of a hernia. Everyone has experience here doing it. What do you guys do?
Yeah, I had some cases of even large hiatal hernia, and I didn't, not only I didn't prepare it, but I came laterally and I did I prepared my gastric pouch, and when the anastomosis is done, it will make the hiatal hernia to be reduced into the abdomen. And even I had a giant hiatal hernia that was about half of the stomach and a part of omentum in the mediastinum, and was herniated to the mediastinal space. And I did for her mini gastric bypass, and recently she came to me and I did I asked her about any sign or symptoms of GERD. She hadn't any problem, and I also sent her for upper GI and barium solo, and I saw that although there is a small hiatal hernia, sliding hiatal hernia, but the size of hernia was reduced, and it was, I think, it's a great success for not only Roux-en-Y gastric bypass to treat the patients with hiatal hernia, but also for OAGB we can use for hiatal hernia, and the patient will have benefit from these procedures as in my experience.
Thank you, Imran. I'm going to pass it on to Professor Layani.
Sir, can I share another video?
Oh, yes, please.
Can you see?
No, not yet.
I can remember, but I have
now you can see?
No, you need to share screen again.
Okay, sir. I will share again. Now you can see.
Yes.
Simultaneously a large number of hiatoplasties. If you have somebody who has a hernia of 2 or 3 or 4 centimeters, doesn't matter. Only just paraesophageal hernias should be closed because they are risky. If you have, for example, we have done also MGB cases after upside down stomach. Yeah? Patient coming with upside down stomach, we have obesity, and finally you have to bring down the stomach in the abdominal cavity, and then the question, what do you do? Will I do a sleeve, or I do an MGB, or why? So I was against the sleeve because the sleeve will move very fast again up into the chest, because longer existing upside down stomach, you have a shortened esophagus, and this all the time will draw up the sleeve maybe back again. The idea is, if you perform a bypass with all the weight of the limb, also the intestine in the standing position all the time, it draws down. It's a good option, and you have a guarantee of weight loss. So we have, I've done some cases, upside down stomach in the same procedure, MGB as a bariatric procedure.
Sir, please, over to you, sir.
Thank you, Imran. Professor Layani.
Can you hear me?
Yes, wonderful. Great to see you.
Yeah, thank you. Luke, listen, I mean, this question is quite frankly simple to answer. Every single patient with a hiatal hernia should be repaired. I do a lot of hernia surgery. I train in hernias in fundoplication before I was doing even bariatric surgery. I do believe every bariatric cases, whatever you do, a band, a sleeve, a gastric sleeve, a mini gastric bypass, a Roux gastric bypass, if the patient do have a hiatal hernia or weakness of a diaphragm or a bigger hernia or larger hernia, should be repaired. If you repair from the front, if you repair from the front and the back, or the back only, is up to the surgeon really. The question is more often coming back to the endoscopy is the reason why you do an endoscopy. If you try to, in the ideal world, like Chetan mentioned, it would be nice if we could do before and after on everyone. The fact of the matter is, it's not the case everywhere, and most of the time it's not done for economic reason. So really, if you have the chance to know, if you know in advance where you're going to, means you know in advance, and then you have perhaps a large hiatal hernia, it might change the type of surgery you're going to do. But to answer more about your specific question, the answer is very clear. You'd have to fix all patients, in my mind. To give you an example, I stopped doing band for a long time here, but probably around 40 to 45, even maybe 50% of my sleeve gastrectomy, I do repair some kind of hernia, weakness, hernia, defect on every single patient, every single week. So I think for MGB, it should be done. I know I discussed this many times with Robert, but I do believe that it's a very simple thing to do in my mind, in my hand, and it should be done. I don't like to see patients with the mini gastric, with the gastrojejunostomy in the chest. I think it should be done. It doesn't mean that every time you do it, it's going to be fixed forever, because you know, and I know that if this can fail, it can recur, but I think it should be done. Full stop.
Thank you, Professor Layani. It's great to hear from you, and we are definitely out of time for these 5 questions. So I'm going to pass it on to our next summary of questions, and our moderator is Professor Asim Shabir, who's going to be asking the next series of 4 questions to our expert panel.
Lovely. Thank you very much, Ariel. You can have a break, get your coffee. You all guys, do we need a little bit of time, everybody? Are we all good to go ahead? All right, so thank you very much. This section largely will deal with some talks about marginal ulcer, a little bit about bile acid reflux, but largely will continue to concentrate on gastroesophageal reflux disease, peri-1 anastomosis bypass. So it's again my honor to have all of you as my panelists, and we look forward to learning from you. So I think we'll start off, since we left at the marginal ulcer business just now, let's start off with the marginal ulcer. So are you guys really concerned about this marginal ulcer? Let's hear from a few of the experts who've been on this meeting before, and then we'll come to the panel. Imran, over to you for the videos.
Okay.
Absolutely, I can share. So I'll give you a nutshell. So, I've heard that from surgeons that mini gastric bypass has same marginal ulcer rate as like a gastric bypass. I disagree. We have a 10 to 15% marginal ulcer rate with mini gastric bypass. Now, those mini gastric bypass surgeons who would say that no, there are no marginal ulcers, they are trying to kill this procedure. And Dr. Imran, you have to understand that I'm myself saying that I do this procedure in the largest volumes. Now, if I feel that there are 15% marginal ulcer rate, I should report it. It's ethical. It's ethical to report it. One is basically, I would say, it's his responsibility to report a 15%, 10 to 15% marginal ulcer rate, which is higher than my gastric bypass, because I do my gastric bypass patients endoscopy as well, which is around 5 to 8%. Now, why we find them more? Because we look for them.
Yeah.
We look for them.
Yeah.
If you look for something, you're gonna find it. If you don't look for these things, because you know what is interesting? 80% of these patients who have marginal ulcers after mini gastric bypass are asymptomatic.
Yeah.
So, MGB says, no, patients won't complain. There is no complaint. But the point is, these asymptomatic marginal ulcers are there in the small bowel side, in the jejunum, and they are the ones which causes perforation. And this patient lands up with a perforation peritonitis in some other city with some other surgeon who does not know anything about one anastomosis because he's a general surgeon. And then we are stuck. So my point is that please remember there's a 15% incidence of marginal ulcers post mini gastric bypass at 2 years. There is a good rate of bile gastritis after mini gastric bypass, which is expected. We do not see a lot of strictures these days. No, I haven't seen stricture 0.001%. I'm not seeing strictures. Obviously, the anastomosis is quite good and quite spacey. We see strictures only in patients who have chronic marginal ulcers. The rate of esophagitis after mini gastric bypass is less than that of sleeve. So whereas sleeve patients will have around 15 to 20% of esophagitis, MGB patients will have 5 to 8%. Gastric bypass almost similar. But marginal ulcers, let me be honest with you, it's a 15% incidence.
Sir, I will share another video. Just a minute.
Sure. Please go ahead.
What we have learned in the years of before 2014.
Imran, I can't see the video. You probably have to share again.
I will share, sir.
After surgery.
We can hear the voice, but not the video. Imran.
Oh, no, I will show you. Now you can see.
What we have learned in the years of before 2014, we have done only just BBI medication for 3 months after surgery, also after Roux-en-Y, after MGB, after all procedures. And then we saw some cases of marginal ulcers. We extended the time for 6 months totally, and then we stopped. And and it's surprising, the number of ulcerations and such complications dropped down markedly. So to have a half year or maybe 1 year PPI medication after gastric surgery and after bypass surgery, Roux-en-Y, MGB, whatever, it's a time to adapt the gastric mucosa, whatever. After such a period of 6 months, PPI medication, you have extremely less, except smokers. If you have, the patient will come with a gastric perforation after MGB or after Roux-en-Y, you know it's 90% it's smoker.
Sir, I have another video, just I will share with you.
In my opinion, it's not related to the technical issue. It's related to the multidisciplinary team. For sure, now we have less problems than before because you learn more and more, and you may modify your technique without you feel even. You find your one anastomosis gastric bypass or your bariatric surgery practice becoming more clear and more organized than before. So with a multidisciplinary team, with the proper nutritionists and with the proper lifestyle coaches and with a proper follow-up, you'll find less and less problems not regarding reflux only, regarding any late complications after bariatric surgery. So yet, if we compare it technically, actually when we minimize the stoma to 3 centimeters, I think that, and we do a very straight monopressure longer pouch, I think that the reflux is becoming less. Yet we don't have enough clue about this. I think that we follow the patients very well. We chase the patient everywhere, and maybe that's why we have less problems. And when we conserve the patients and do the medication as early as possible, I think we avoid a lot of problems lately.
Sir, please.
Lovely, thank you very much. So let's go on. I've got a couple of questions here. My first question comes to technique. So we saw in the last video, there was a mention about reducing the size of anastomosis. Now, I've heard the other videos as we started, some people talking about wide anastomosis. And now here's another one of our colleagues. So what is the consensus then? A wide one, 4.66 centimeters, or a 3 centimeters? Can I start with Professor Loren? Sorry, I think you're muted. You may want to unmute yourself.
Yeah.
Lovely.
Yeah. Can you hear me?
I can.
Yeah. Quite frankly, I think the technical aspect of the marginal ulcer has a relation in the early one. Perhaps in the patient with ulcer in the following 3 to 5 months, because some guys, they're over suturing, they're tight, it's ischemic, it look ugly. I've seen some cases and it's look like actually horrible. Now, and this is what I think the early marginal ulcer technical related to the technique. The late one is probably related to smoking and to the fact that it can happen to any gastrojejunostomy. But to come back to your question, because I understand your question, is the marginal ulcer has anything to do with the length and the size of the anastomosis? In my view, the answer is no.
Lovely, thank you very much. Professor Enrico, so what we have learned here, there's an early marginal ulcer, there's a late marginal ulcer. I think the OAGB, MGB community largely agrees that the later ones are hyperproductive due to acid, and most common insulting factor being either a H. pylori infection or smoking being the most common reason. But let's talk about the early ones. So a longer parallel staple line anastomosis, that does then predisposed to development of marginal ulcers in all the patients, and thus a 6 months course to allow adequate healing of that ischemic area is something that you would attest to?
Yeah, this is one of the differences between MGB and OAGB. Both are, of course, wider than the Roux-en-Y gastric bypass, as you know, the standard is 1.2 centimeters, which aims at a more restrictive operation. So MGB calls for an restriction without obstruction with a very wide anastomosis. I think I've heard and read 6 centimeters even. We, with the OAGB, are not as wide to this. The widest we advertise or we propose is 3 centimeters, between 2.5 and 3 centimeters. As far as the pathophysiology of marginal ulcer, we all know that this is acid more than bile. And many skeptics call for an increased incidence of marginal ulcer after MGB or OAGB because of the bile. In fact, we and Dr. Chevalier, in discussions that we wrote different articles, we have proposed that probably if this is the case, the incidence would be lower with the MGB OAGB because the bile may be acting as a buffer in this kind of operation. This is only a hypothesis that has not been proven, but this is something that I think should be studied. I do believe that, as far as my experience is, that most of my patients that have had marginal ulcers do have some of the risk factors that have been implied for marginal ulcers, especially smoking. And we try not to operate on smokers, or we call them, to stop smoking before the operation and tell them to not take the habit again after operating. But as you know, this is very difficult. So most of the marginal ulcers that we've had are from smokers. And I think from the literature that has been also the case.
Okay, thank you very much. I think Professor Rutledge would like to make a comment. Professor Rutledge, over to you. If you don't mind, could you on your camera and your mic? Right, I think while we wait.
Well, I can jump in for a second. I'd be happy. I've only had one marginal ulcer in my entire series. And we try to select our patients very carefully, as well as has been stated. I find the interesting thing is I have a marginal ulcer right now in the hospital on a Roux-en-Y gastric bypass I did 3 years ago. Marginal ulcer and Roux-en-Y gastric bypass is very common. It's sometimes just treated with PPI, sometimes they're superficial, but it's not uncommon to have a deep eroded marginal ulcer. And I really think that the construction, when we look at probably the first most important component is the length of your mini gastric bypass pouch. The second will probably come in the future to be how we construct the anastomosis with respect to marginal ulcers. The passage of the biliary pancreatic secretions, it's just my belief, but I think that is the single most important component that buffers against getting a marginal ulcer that really takes hold. The one patient that I had an incredible stress response. One of those things where the patient is under incredible stress. She had no smoking history. She had no NSAIDs, but she had been living in an incredibly stressful situation for 3 months. And then she perforated an ulcer. I've never seen any endoscopic evidence of ulcers on my series. So it must be more protective, because the only thing I'm doing different from my Roux-en-Y gastric bypass is that I have a loop reconstruction instead of a Roux-en-Y.
Lovely. Thank you very much, Dr. Almond, for that. Dr. Rutledge, you're next up.
Yes, sir. So I'm going to share my screen. I have a drawing or two to show, if I may.
Yeah, please do.
Okay. Okay, share screen. Can you see the screen?
Yep, we can.
Good. So I'm going to talk briefly about marginal ulcers. And When I say briefly, I realize that most of you know that's rare for me. But basically what I wanted to talk about is there's a lot of discussion about acid and other problems causing marginal ulcers. And of course, smoking makes a difference in all series of ulcers. But one thing I wanted to bring up is that what we've heard or what we can hear or what we've heard today, even in the few people who have spoken, is a paradoxical difference in the reported rates of ulcers, but not just ulcers, in a variety of other components of this operation. We know that some people are anchoring the gastrojejunostomy, we've heard. We've heard other people routinely closing the hiatus and other things. And I think that it's important to recognize that these experts are reporting different results and with different technique. And so there's a possibility that technique makes a difference. So one of the things I wanted to point out is when we think of the distal gastrojejunostomy area, there are some things that I think about that might be useful. One is that the only vascularity to this gastric tube is now from the right gastric arcade, the short gastroepiploic, and I'm sorry, the left and right gastric. The neo-greater curvature, of course, is stapled, and so it has no further gastroepiploic blood supply. And so what I wanted to point out is the placement of this staple line for the gastrojejunostomy. If it is placed, say, for example, where the red staple line is here, then we have two staple lines and we've created a potentially ischemic zone where very little blood flow will be placed. And now if that is also an area with a large amount of staple foreign bodies of titanium over the long term, ischemia plus foreign body plus being in a digestive environment, this particular gastrojejunostomy, I think, is at higher risk of marginal ulcers. Conversely, as the staple line moves closer to the lesser curvature, then we have more opportunity for collateral flow. And my own opinion in looking at and consulting with surgeons who will occasionally call me for my advice is if you look at the surgical videos, which many of the surgeons who share problem patients with me show me, this might make a difference. So that's one thing I mentioned for a brief discussion here, and I'll stop and take further questions if you're interested.
Lovely. Thank you very much for that very interesting concept of yours, and I totally would agree that where you place your staple line makes an absolute difference. Otherwise, that small little patch of gastric tissue that comes with the parallel staple line becomes ischemic, and that takes about 6 months. Either you oversaw it and leave that raw ulcer, or you stay quite nicely. Thank you very much for that, Dr. Rutledge, and I'll come back to that. Dr. Kuller, over to you. How long do you use your PPI? I understand you're about 6 months of PPI usage post MGB.
About the PPIs, in the beginning of my practice, like 16 years back, we were using it for 3 to 4 months. But at present, we give it only if the patient is symptomatic. Otherwise, yeah, we don't feel that it makes any use of any.
All right, that's interesting. So what I had most of the experts here was that they would use it for indefinitely, about 6 months at least. Okay, so yours is not really, if they're symptomatic, then you use that. So then on that, Dr. Kuller, if you're going to use these PPIs for these patients, how didn't you look out for these symptoms, or are you one of those consultants who would not offer an MGB to a patient who smokes then? Are all of us on this forum agreeable that if a smoker comes in, we're not going to offer OAGB, MGB to these patients?
It's not exactly like that, because we have, in our area, we have many females who never smoke, but they take the painkiller medications, the NSAIDs, quite frequently. So even they have a higher incidence of ulceration. So we keep following these patients very closely. Every day we are calling 30 patients and keeping very close track of these patients. If any of the patients is symptomatic, then we tell them to take the PPIs for 4 to 6 weeks. And we train them that whenever and if they have any heartburn or such problem anytime in life, they should take the PPIs. And if it's not coming down, then they need to get an endoscopy done. But otherwise, giving it just for like 5-6 months after surgery and then stopping it, I would see no use in it, because the ulceration which comes up early is generally because of the technical factors, as it's very clear in our practice now. And in the long run, you cannot keep the patients on antacids throughout the life. Yep.
Thank you. I'll come back to that, Dr. Chetan, before I come up to you to ask you about the literature and about nutrition, which was spoken to as a contributory factor to the ulcer formation. I'd just like to comment on Dr. Hellman's comment using of ICG. It would be really interesting to publish that outcome, because it will show us how that bridging tissue, that large bridge that you have with the 4, 5, 6 anastomosis, what's the viability on ICG of that? I use them, but I use them for my proximal gastrectomies for cancer, but not in my bariatric practice. So that would be very interesting. Is there something that you would like to share in brief with us, Dr. Helmut?
Yes, I am a big fan of ICG. I've been using it
Lovely.
since it first came about. I find it particularly useful in MGB to give me very high level of confidence. And perhaps if we do one of these in the future, I'll be able to pull my series and show you and have you tell me whether you think these images are useful for you, because I don't see the bridging ischemia, although I completely accept the theory that these staple lines are going to cause zones of ischemia. I haven't been seeing it on ICG, and I do them on my bypasses as well. I have occasionally seen zones of ischemia where I'm surprised, and sometimes it's not in those locations, but it allows me to immediately alter my technique to take those into consideration. But I think the final verdict on ICG is not yet in as to its usefulness, but I certainly at this point find the images very helpful.
Can I comment?
Yeah, please, Dr. Ratledge.
Dr. Billy, you said two things, which I think they might be related. You said you use ICG, you do not see ischemia, and you have very low rates of marginal ulcer. The one might be causative of the other. What would you say?
I think it does guide me as to how I'm going to do my anastomosis. I find great value in seeing where the arteries are. The major arteriogram from the ICG is more important to me, because I will rotate my anastomosis away from possibly damaging those major vessels. And it will guide me whether I choose to do it anteriorly or posteriorly, because my vertical staple line is never in the perfect location with respect to doing an anterior anastomosis or a posterior one. So I'm trying to use it to customize my anastomosis so I have maximal perfusion. And maybe my outcomes are just luck. I don't have any data to prove that it's improved my ulcer rate.
Well, just to make one more comment, as far as anterior and posterior, if there's subsequent interest in discussing that, I have some photographs, but I have photographs where you look at the technique and it seems obvious just looking at some of these approaches to the gastrojejunostomy where you're putting staple line next to staple line that there's a potential for ischemia. But I would posit that your good results of low incidence of marginal ulcers, a good visualization of vascularity from the indocyanine green are all related.
Well,
Well,
thank
I
you very
certainly
much.
hope so.
Thank you. I think a very good question for the future research and hypothesis building, and certainly Chetan would be interested. I see him smiling down there. I've got another project to do. Chetan, over to you.
Yeah, that's exactly I was thinking. I'm going to email Helmut with final details, because my one simple question to him here would be that from his experience of whatever 100, what would he have done majority of the time? Would have been it a posterior or an anterior, or would it be in midline like Rutledge was saying, or would it be towards that? So what's your maximum you would have done, Helmut?
Well, I think I'm starting to rotate my initial vertical staple line, the one that's 15 centimeters away from the GE junction, so that it gives me more anterior purchase, more anterior tissue to work with. I think my preference is to do it anteriorly because I can see the whole thing, but only if I have excellent arterial blood flow and excellent perfusion. The more anterior tissue I have, the farther away that bridge between the staple lines will be, and hopefully it'll be better perfused. But I haven't come up with a preference other than I like doing it anterior.
Okay, fair enough.
Thank you. Chetan, your final comments. We got to move on to the next question.
So I think talking of marginal ulcer, yes, I think it's one of the Achilles heel, just like internal hernia is the Achilles heel of Roux-en-Y. I think there's a lot of debate, but I don't think that the rate is as high as 15% as what Mohit was saying. I think there is a lot of literature out there which says it is acceptable and kind of comparable to Roux-en-Y, or maybe 1 or 2% less. And actually, just going back to Mohit's video, Imran, I think if you listen, and also he said 10 to 15%, but in OAGB, but then he also said he had 8% marginal ulcer in Roux-en-Y as well. So I think you have to then look at a balance, because maybe he's scoping all of them and finding, he then said he found 80% were asymptomatic, which probably none of us do that unless there is a protocol of post-op endoscopies in all of them. And rather than in the same way, preoperatively, if we do endoscopy, I find a lot of asymptomatic patients with no history having ulcers and, those things. So I think that's, you'll have to take that as a pinch of salt, the whole scenario. Talking of PPI prophylaxis, I think as far as literature shows us, I think if you look at the median, I think majority of them tend to give between 3 to 6 months is what they give. There are a few literatures of some people giving 1 year. I think that there are even one series where they're trying to suggestion that give it for 5 years. If you look at the IFSO consensus statement, I think agreed was 3 to 6 months by the world experts. And if you look at the marginal, not marginal, if you look at the GJ anastomosis size, I think 80, as far as I can remember, 89% of the experts agreed that it should be 3 to 5 centimeter GJ anastomosis size.
Great, thank you very much. Okay, now let's move on. We're going to go into the real exciting field of MGB, OAGB, and reflux. All right, so guys, we've got different scenarios, and I'll just put it very clear. We're going to go into the first scenario is where it's talking about GERD and performing a primary OAG MGB. Imran, do you have a couple of videos for us?
Yes, sir.
Lovely, go ahead.
Can you see now?
Yep, we can see.
I prefer to make a chloroplasty at first and get the proximal pouch down of mediastinum, because negative pressure at the mediastinum maybe induce some problem in the future for the case. And for GERD, continuous and prominent GERD after a sleeve gastrectomy, I prefer to change it to low pressure operation, including gastric bypass, mini or Roux-en-Y, or now in some cases I have an experience of SASI operation, 350 centimeter proximal of ileocecal. By this way, I think the GERD secondary to sleep can be stopped. But my experience, my prominent experience is to change it to, if the grade is 1 or 2, to mini gastric bypass and chloroplasty, and my cases are happy.
Okay. Sir, I will share another one.
Please do.
More about the GERD. Previous GERD and after surgery. I have published recently, two years ago, my results, very long-term results, and with a control of the previous GERD very, very good in 92% of the patients. Also, a few years ago, I operated 2 patients with endoscopic diagnosis of Barrett. Barrett disease, in these 2 patients, the Barrett disease disappeared in the long-term postoperative controls. So this is my experience, but that does not mean that I advise everyone about the OAGB in Barrett disease. This is clear because the guidelines have not approved this indication. This is important to know. I perform, but my advice to mainly to the younger surgeons is not performing Barrett because the guidelines have not this indication. However, I do advise OAGB in patients with GERD or with esophagitis in E or B esophagitis. These classes of esophagitis, it's an indication of OAGB. I think the esophagitis, in my experience, disappear, and the GERD in 92% disappears. The rest it improved. So I think this is a good change, contrariously that in the past any people can explain.
Sir, I have another video. Just a minute. So
Okay, so while Imran uploads that video, I just want, for this section, I will ask the experts to comment on 3 things.
Sir,
and I'll tell you
discuss with the patient. And usually such patients are knowledgeful, so we will discuss both options of RYGB and MGB. And I am quite personally comfortable doing MGB in these patients. You have to make sure that you have a nice wide anastomosis. If you have a nice wide anastomosis, that means the food is passing from high pressure to low pressure area. The GERD actually becomes better.
All right, Imran. Let's start with Dr. Kuller. Dr. Kuller, are you there? Can I have your mic?
Yes, Dr.
Lovely,
Asim.
thank you. Lovely, thank you. So I have 3 questions in this subset. First of all, primary GERD, LA grade A, B esophagitis. Would you do this procedure?
Yeah, definitely. Now
Lovely.
Things are very, very clear. I would go in for MGB, primary GERD patient clearly. As we look into our series of last 16 years, we have tried doing other things like Roux-en-Y's or doing Brown's, jejunostomy. But now we are doing simple MGB in these patients. There are 2 reasons for this. Number one, looking into the literature, now it's very clear, as established by Professor Tolini from Italy. He has checked the pressures inside the gastric tube after MGB. We know that it becomes a low pressure system, and relatively the same GE junction becomes stronger because there is nothing at the outlet. And
so, Dr. Kuller, let me ask you that. Then if you have a hiatal repair to be done, would you just do a simple hiatoplasty, or you will combine hiatoplasty with fixation of your esophagus? Do you anchor your esophagus somewhere around? You put a stitch to the crura with the esophagus?
Yes. Again, this is very, very clear now, because with MGB, you have additional benefit that the mesentery, because the loop is hooked to the gastric tube, mesentery is all the times pulling it down, and the GE junction stays very well inside the abdomen. And practically, we don't have to fix anything anywhere. And as majority of the hernias are type 1, sliding type hernias, they respond. Even the symptomatic hernias with GERD, they respond very well, even if you don't do anything at the GE junction, like putting any stitch at the hiatus or doing a fundoplication there. Yeah.
Thank you very much, Dr. Layani. Over back to you.
No, hang on. Yeah, listen. Yeah, first of all,
Yes,
your
yes, go ahead.
question. Yeah, no, it's okay.
We love you.
Fixing the esophagus after you repair the diaphragm with after your hernioplasty, regardless of the technique you use, fixing the esophagus like we used to do, or I still do sometimes for achalasia, is it going to make a difference post-operatively with your reflux? To be frank with you, the answer is no. I mean, to be honest, you're going to dissect the esophagus, you're going to do a right crura esophagus, left crura esophagus, you put 2 stitches and you put why not? I still believe then sometimes keeping the mobility, keeping the dynamic of the abdomen and the thorax is perhaps better than fixing the complex, like we sometimes, even I used to do for radical gastrectomy, but I used to do this mainly to fix the anastomosis in place. You know, I'm sure you know what I'm talking about. So this makes sense. In a term of reflux, the unique thing sometimes you can do, if you believe on this, rather than fixing, is to try to repair the dissected phrenoesophageal ligament, like a 180 degree, not 360, but 180 degree, to try to balance this. So this is the answer to your question. But what I would like to give you a very quick answer. It is very important for the surgeon to have a very clear idea of what exactly is going to do. Is it going to, and I agree with Miguel, I'm very much like Enrique and Miguel, except I have never pushed to do a mini gastric bypass for proven endoscopic biopsy of Barrett's esophagus. But the truth of the matter is, this is very rare case. How many patients with reflux, endoscopic examination, biopsy, are you going to find a proven Barrett's? If you take this to the number of patients you do, is very few. I still believe it's a good way. It's perhaps the unique indication for me is with this kind of Barrett's, proven Barrett's, is to do a Roux gastric bypass. Otherwise, all the patients with symptomatic reflux, endoscopic proven reflux with esophagitis, I do an MGB. And you know, and I know that the reflux will go with for 2 reasons. One is the surgery. Number 2 is the weight loss, because they all have symptoms of reflux because of their obesity.
Thank you very much. Dr. Enrico, would you like to comment on that?
Yes, several questions. As far as the hyatoplasty, our technique in opposition or in contrast with MGB, we do specifically dissect the OAGB, the upper, and so we do that, and in most of the cases we reduce all the hernias, either if they're small or large. We do a hyatoplasty in those that are large, and if, like someone was saying, if we have the data or the information preoperatively, either by an endoscopy or at least the barium swallow, because as I told you before, we used to be very selective in doing pre-op and post-op endoscopy only in symptomatic patients, but we always did a barium swallow preoperatively as a map of what we were dealing with. So if we found a large hernia, of course, we would do a hyatoplasty. I think Laurent was talking about having an anastomosis up in the chest. I think if you do a long pouch, as we try to do all the time, it would be very unlikely to have a gastrojejunostomy or an anastomosis up in the chest. And this is probably the most important thing to avoid reflux. And one of the things that we've changed over time is the length of our pouch. We used to keep the neurovascular bundle as you do in a Roux-en-Y gastric bypass, coming, separating and technically that would lead us to go as low as only the crow's foot. If you try to do that down, longer than that, it's very difficult. So in trying to do a longer pouch, we now sacrifice and we divide the gastrohepatic ligament. We take all that, and we are able to go as low as almost 2.5 centimeters from the pylorus. This gives us a very, very long pouch, which will very unlikely go up in the chest and will lead to a very good anti-reflux procedure. As far as our results, as Miguel told you, and you've seen probably this long-term follow-up of 1,200 patients where we followed up from 6 to 12 years. And we found that OAGB was an excellent anti-reflux procedure with remission of GERD in 92% of the patients and improvement in the 8% and the other 8%. So all of them were benefited from the operation. I think, like I said, the most important thing is to do a very long pouch. When we've seen reoperations, either with MGB or OAGB due to reflux, I recall one paper by Facchini, I think from Italy, where he precisely informs of the findings of the operations, and he found a 5-centimeter pouch. Well, that's the usual thing. These patients that need reoperations for reflux usually have very short pouches. And in a letter to the editor, we said it's very important that when reoperations are carried, findings are informed. If you only say MGB and OAGB and we had to reoperate all these patients, tell us your findings. What did you find? What kind of pouches you found? And lastly, as you know, because we have found this to be a very good anti-reflux procedure. In fact, it's a very, very long Colles operation. We do this operation in any type of patients with GERD, even severe chronic GERD. And as Miguel told you in the video, we also do it in Barrett's patients, provided we do have a very strict endoscopic follow-up. I think it's a better operation for patients with reflux, even with Barrett's, than the sleeve gastrectomy.
Lovely. Thank you very much for those comments. I'll move on to Dr. Kamal Mahavar. Is Kamal around somewhere here? Kamal, could you open your mic? Can I see your screen? My question to Kamal is, so OAGB, MGB, same names, one over 36 French bougie, the other a little bit more dilated. We're talking about pressure, we're talking about reflux. Comparing the two, I know the techniques are relatively close by, but then certainly there would be a bit more pressure on one because of the construct of the gastric tube, just like the sleeve gastrectomy, although the distal end is low pressure, but within the pressure itself, within the tube itself, the pressure would be high. Kamal, are you there to help me comment on that? What does literature say about that? Chetan, would you like to take it? I think I don't see Kamal here though.
Yeah. No, I can't see him. Sorry, I didn't listen in detail. I got just disturbed by a
okay. No problem, Chetan. So I was asking that one procedure requires a 36 French bougie. The other is done with a liberal width, right? With 1 centimeters away. So there are pressure differences. Do these pressure differences then translate, like the sleeve versus the bypass, then translate into more GERD in one versus the other?
That's a very interesting question. And believe me, Asim, if I could answer that really, this whole debate of reflux would be put to rest quite easily. I don't think a straightforward answer to that, because I think Kula just referred to the Italian paper for Vitalone, and I think they very well measured the different pressure difference after MGB, sleeves, Billroths, and thing, and they did find that the pressure difference, the whole esophageal gradient, the lower esophageal sphincter pressure, everything is quite different, and everything was more in favor of MGB. Now, as you know, I think everybody says MGB, OAGB, but I still think majority of people kind of have some hybrid thing there, that, they put that one stitch just off that afferent limb, not really religious as Enrique and Miguel would do, that they would make an 8 to 10 centimeter afferent loop up. But I know majority of them just putting 2 stitches there. And some people, as Vijay Lee's video, Imran rightly showed, that now some people have started suturing the pouch to the remnant, and then some people have started suturing the efferent to the gastric remnant. So I think the correct point is that if somebody, as Lauren was mentioning, and Enrique mentioned, that if somebody is doing a revision, I think they need to really mention the intraoperative findings, that what actually is there. And if you look at that large multi-center paper from Europe, I think the bottom line there for reflux and all was that if you have a smaller than 9 centimeter pouch, you have higher inclination for reflux. So you need at least 10 to 12 centimeter or even longer pouches. And personally talking, I think the difference, what I have realized looking at literature, is if you look at all smaller series, 20 patient series, 30 patient series, their reflux and marginal rates are higher compared to somebody who has done 100, 200 or 500. Their marginal, and I think that learning curve you do have to accept. And I think, as Kular again mentioned, it's the Roux-en-Y surgeons trying to increase slowly, that it's tricky. It's difficult to move your first staple line to crow's foot and even more distal. I think those are the learning point. I remember when I did my first MGB, it was at crow's foot. But now if I do it crow's foot, I will myself say my pouch is small. I have now moved to distal.
I agree. Thank you very much. Dr. Hellman, to your comment, I'm not sure, is Dr. Hellman's comment, is anybody doing a links procedure together with MGB or OAGB? I've not had the personal experience. I've had experience with links, but with other bariatric procedures, but not with MGB or OAGB. Is there anybody else who's got that experience? I guess the experience is limited, and we defer to you and look forward to listening to that across some time about this new innovation. I think, do you have anything offhand, Dr. Helmut, to share with us?
I think the uniqueness of our approach has been to identify the patients pre-op that impress us with their hiatal hernia or the severity of their reflux that we have identified going into surgery. And so we have chosen to do 2 operations. First, the repair of the hiatal hernia and the links, and then prove, 1, they can tolerate the links, and 2, the reflux is no longer present. If they can't tolerate the links, I can take it off. It is not as difficult as we may have seen. I have multiple presentations of linkses that had to come off for various reasons, none of which had to do with erosion or something bad. But when I get a patient that has an excellent outcome with the links, reflux is no longer an issue on any of the bariatric procedures, including MGB.
Okay, great. So thank you very much for this. In the interest of time, we would then now continue to move on, and we move on to a very crucial topic. This is related to revisional surgery for patients who've actually had intractable GERD following a laparoscopic sleeve gastrectomy. Here are the videos. Let's look at them, and then we move on to the Q&A.
For every revision cases, because there's always different in patient previous surgery and also the symptom of the patient and the requirement of patient. So we need to individualize. So my first thing is to is this patient have reflux? If the patient have significant reflux after sleep and is suffering from this, I will do a Roux-en-Y gastric bypass for the patient.
Sir, I will share next video. Just a minute.
So we've gone through what people do, hysterplasty, stitches, and all that. So we need to address the other part of this.
But all the time, if you have a migration into the chest, into the mediastinum, you have to bring it down.
Yeah.
Otherwise, it goes drawing of the lumgus. It's like goes all the time. The power goes up and is moving more and more. But you have to bring it down and close the diaphragm. But here, the hysterplasty itself is no anti-reflux procedure, and maybe you have to fix the sleeve on the left cruise. But finally, far away from this, make it in a low pressure system with a wide anastomosis, and then everything goes in one direction, not up.
Sir, can I share another video?
Imran, in the interest of time, shall we just go through the expert panel?
Okay, sir, please.
I think. All right. Okay. Dr. Liani, again, so being a reflux expert, here's a problem where most of us see that the sleeve migrates into the thorax. So MGB, yes, no. And would you really make an effort to bring that gastroesophageal junction below the diaphragm? And what is your trick to keep it there?
Well, first of all, this issue of reflux, severe reflux or reflux symptoms after sleeve gastrectomy, and seeing patients coming to see you or to see me basically for an option is probably half of my MGB are performed, or probably even more, for revision than primary, which is very, very interesting because, as you know, the Emirate, this country, are not very keen on primary MGB. So more than half of my patients are this kind of patient. So I believe reflux after sleeve, if it's 1 year, 2 years, 3 years, 4 years, whatever. First of all, it's one of these indications to understand what is the reason of the reflux. Most of the time, it's an anatomical problem of the sleeve. Rather, it's the sleeve is migrated in the chest. Rather, it's a dilatation of the upper sleeve. Rather, a champagne bottle sleeve. Rather, is a little bit of narrowing. Whatever it is, most of the time, it's an anatomical problem. So I revise very commonly, probably one every week, sleeve to MGB. So, and I believe revising sleeve to MGB for reflux problem, it's a very, very good operation. What you have to do is simply refashion the anatomy. It's all about the anatomy. If the OG junction is in the chest, you bring it down. You cut you redissect completely the previous sleeve to assess what kind of sleeve has been done. After you have dissected completely the sleeve, you transect the sleeve from left to right above the pylorus. So you probably have a very, very long gastric bypass. Then it is very important to see, are you going to re-sleeve the tube or not re-sleeve the tube? And probably half of the time, or maybe more, you need to reshape, or you call re-sleeve the tube. And how do you know this? You put the bougie inside your previous sleeve, and you assess if the tube is small or big or need to be reshaped. So this is number one. So the answer is and number two, I believe for revision patient, you need to bypass the patient more than the primary patient regardless. So you have to increase the length of your bypass if you believe on tailoring the patient with the BMI, which I do believe, and I'm sure Enrique is believe the same. If we look at tailoring the patient with the BMI, then when you do a revision, particularly sleeve to MGB, you need to increase the length of your patient. And this is where I have learned from Enrique and my Spanish colleagues. And this is where, because I increase the length of the bypass, I do count the length of the entire small valve in this case. You can come back to me and say, why you don't do this all the time? Right now, I don't, but I do for the revision.
Thank you. Enrique, since you've been mentioned here, what is the logic behind increasing the BP limb length to accommodate for reflux? Could you share us for the audience purpose?
No, for the revision we talk about.
Yeah, I'm talking about the revision. Why do you tailor to increase the BP limb?
Well, as you know, we really favor both in primary and revisional surgery as an integral part of the operation, counting the whole small bowel. In a technical standpoint here, as you may know, or most of you know, we count from the right of the patient and not between the legs in the French position. This makes it much more easier. We follow the route of the mesentery. If there's time afterwards, I'll tell you the technical details of the OAGB as opposed to the MGB. But we do count, and then if this patient is being reoperated only for reflux, then maybe I don't agree in going very far. I mean, being aggressive in the malabsorption. But most of the time, these patients do also have problems with that they've been stuck in their weight loss, or they've even increased their weight loss. So if we're operating also for a failure as far as weight, we are more aggressive in this, and we tailor the operation in that sense. Maybe what Laurent is trying to say is that if there has been a failure in weight loss, these patients kind of are resistant to the operation. And so we do have also the same approach when we fail with OAGB, which is seldom, but we fail in the weight loss of the patient in giving them a longer BP limb and shorter common channel. So maybe that's the sense of this. As far as all the technical standpoints of Laurent, I agree fully in retrimming the pouch, doing the hyatoplasty if that's the case, going as far as possible, almost to the pylorus in the section. All of that, I think, is the same way we do it.
Thank you. Is there anybody who's got any other comments on this topic of post-sleeve gastrectomy conversion to MGB phenomenon? I think we all agree in the panel that if this is the way, then this is the way to do it, and that it gives results, and we know why.
But the problem is not about you guys to convince, but is when I talk with most of my colleagues and I see patients all around the UAE with these reflux symptoms after sleeve, and you can imagine a lot of patients do have this problem. A lot of sleeve fail, a lot of sleeve regain weight, a lot of sleeve do have some reflux, and most of the time they have both. They have all. They have the reflux and they have the regain, and they regain the weight. It's for some reason most of the time together. And when you look at the number of surgeons offering mini gastric bypass after reflux and or weight regain after sleeve, it's very, very few. They think it's crazy to do this. They think they basically want to offer the patient a wide gastric bypass. I still don't understand why. But the truth is what we discuss here is a very small percentage of surgeons around the world will agree with us.
All right, thank you very much. Okay, let's move on to the next because I'm conscious of time and we're already overrunning. Has any of us experienced reflux after OAGB MGB? So here's a patient who was well before and now develops a reflux. Let's get the first few clips and then we go into question and answers. Imran, no voice.
Imran, no volume, Imran.
Exclusive disease for me to smokers. We have to talk about two separate issues. The marginal ulcer, which in our country, we almost always see it only in smokers. It is an exclusive disease for me to smokers. If the patient is a non-smoker, it's very, very unlikely. I've never seen a patient with marginal ulcer who's not a smoker. And again, if the patient managed to quit smoking with intensive medical treatment, he will not need further treatment. It will heal, and you don't need to do any surgical intervention. Unfortunately, for the small percentage of the smokers who persist to smoke, you can have these patients coming with emergency perforation and penetrating ulcers, and you have to do further surgery, or indolent ulcer which refuse to heal with even medications. Again, you have to interfere. So when I visited Philip Shower in Cleveland Clinic in 2008 and stayed with him for 10 days to see their practice in Cleveland, he was at the time, they strictly refused to do any bypass surgery for smokers. They refused it. So if you are wise enough, you can minimize the incidence of your marginal ulcer by selecting your patients from the beginning, avoiding smokers, or making sure that your patients avoid smoking. The technical issue about causing an ulcer, technically, which will present in the first 3 months, not the standard ulcer which present in the first 18 months due to technical issue of ischemia or crossing two staple lines. I think this is avoidable in proper training circumstances. You can technically avoid this issue. As regards the biliary reflux, I think, again, it's very inflated in the literature. I have only revised patients in more than 2,000 patients. Only 2 cases I had to redo surgery for them for biliary reflux out of 2,000. So it's not 3% as mentioned. Maybe some of the patients are symptomatic, 2 to 3%, but the actual percentage which need to go for further surgery is really very, very small, especially if you are constructing your anastomosis wide enough, side to side, not end to side, with some stitches that make it easier for the bile to go down rather than move up. I have never seen an biliary esophagitis after one anastomosis gastric bypass from our center. So I think, again, this problem can be managed technically by altering your technique and training to make sure that this is going to be a very rare occasion.
Sir, can I share that, or you will go for, can I share?
No, let's go. Yeah, please share.
Okay, sir.
Did not do Roux-en-Y. I have diverted Ruiz method, diverted MGB. I had one because of some intractable reflux I have done. And I also attempted one bronze. But to tell you very frankly, diverted or doing Roux-en-Y construction is better than doing bronze. Sometimes bronze will take a longer time to settle down as compared to the Roux-en-Y reconstructions. So my personal experience is that if you have to choose one between bronze and Roux-en-Y reconstructions or diverted mini-gastric bypass, I would say choose Roux-en-Y or the diverted mini-gastric bypass and keep bronze. I think you should not do that because patient will not give you third chance to repair that thing. So we have to do all these things in one go because patient is already suffering. So that is my bias on that. If you have to choose one best thing to prevent this or to rectify this problem.
Sir, just one video, and then
Sure.
we go for
Sure. I like the cool music at the back.
We had a couple of cases of intractable marginal ulcers, and there was 2 such patients. So I do a very simple thing. I always see the nutritional status of the patient. Now, if the nutritional status of the patient is not good because of a stricture which is happening because of a marginal ulcer, I dilate the stricture, but at the same time, I do a feeding gastrostomy. So feeding gastrostomy, I think all your viewers should know that the beauty of mini gastric bypass is that if you feed these patients to a gastrostomy tube, they do pretty well. And plus, once you have treated these patients and the nutrition improves, we will see better healing of marginal ulcers. Because ulcer does not heal because of poor nutrition also. And ulcer does not heal because there is lack of blood supply. Still, the problem is not solved despite dilatation. We have reversed one of the MGBs completely because of the marginal ulcers. And then we converted this MGB into a sleeve because I don't want the patient to go back and get this surgery done, lose all the weight, and then gain all the weight all over again. So we convert this into a sleeve. We have this problem.
Sir, over to you.
Lovely. Lovely, thank you. So can I ask the panelist, has anybody seen a post MGB, OAGB reflux? And how did you guys come across managing that?
Well, we have a problem with patients who had previous lap bands. If I look at my OAGB series that had reflux problems, they are almost exclusively prior lap band patients. And I suspect they had damage and trauma to the lower esophageal sphincter. My current preferred technique for them is to do a brawn enterostomy. With the lap band having been placed and removed, there's very little confidence I have in going back up to the upper foregut to try to address the problem there. So I have so far excellent results with a brawn enterostomy, 40 centimeters proximal, 40 centimeters distal, and I've had nobody that needs reoperation.
Do you mean you do this? Sorry, do you mean you do this electively to all your MGB post lap band? Is what you mean?
Well, no, not yet, but I'm starting to fall into that belief that maybe I should. The incidence of reflux exceeds 50% of previous lap band patients.
You know, Helmut, the problem of the lap band patient when the band is being removed is 2 issues. Number one is this kind of patients have somehow some kind of achalasia symptoms. The esophagus is not pumping, and they will never pump the way your and my esophagus is pumping for a very, very long time, or perhaps for the rest of their life. It's been sort of intrinsically damaged. Number two, probably all these patients need to have a hiatal hernia assessment. They do all have hiatal hernia weakness. So you need, even if you look intact, it's very weak. You need to repair the diaphragm. I believe it's not here. I'm not here to give you advice. I mean, to tell you what to do, by the way. But you need to, because I have changed my attitude over the years of band to from band to sleeve after about 350 when I was still in Australia to now band to MGB. And I very rarely experience this issue from band to MGB, which I do see very commonly from band to sleeve, which I think band to sleeve, it's not a good operation.
So are we, sorry if I may say, are we trying to say that basically an end-stage esophagus that resulted from a band, the sleeve worsens that end-stage esophagus, and then once you can, after that, if you try to convert it to OAGB, MGB, it's not a great option? Is that, do I understand that question correctly?
Me?
No, I'm just trying to put, no, both of you, do I understand the premises correct?
I am surprised of the result of Helmut, because I do a lot of, I do and did a lot of band to sleeve and stop, but band to MGB, my result and experience, I don't see an increase of bar reflux from band to MGB. So I am surprised, or perhaps you haven't seen or maybe look for a hiatal hernia weakness, which probably need to be assessed more.
Thank you, Dr. Billy, up to your comments.
I also think that perhaps my technique has been to stay so close to the esophagus at the angle of His like we do for sleeves, that I maybe need to modify my MGB technique to have a wider pouch. There's a lot of variables there that I'm still looking at, but I was surprised by the amount of reflux that made it out from the stomach into the esophagus in this one group of patients.
Thank you very much for that comment, Dr. Helmut. So since you're a great fan of these new LINX devices that you are putting in, do you have any, I mean, this is just off the record for those patients with sleeve, because I see them as an end-stage esophagus as well. And the outcomes of obstructing phenomena like LINX in these patients hasn't been a great promise to me as well. So what I'm trying to arrive at is, are we actually looking at an end-stage esophagus here, which does not have the ability to push forward the food bolus, and thus, no matter what we do, backfires on us?
I think that's a valid point in my subgroup. If I look at the patients that didn't have any reflux, like have been experienced by other surgeons going from band to MGB, the history of the patients that have the problem are those that kept their band, had the band adjusted over and over, probably was too tight, and now present with an end-stage esophagus. I don't think it's just the band. I think it's how the band was used and the history that the patient endured.
Okay, thank you very much. Dr. Kuller, any experience there?
Hello.
Yes, Dr. Kuller.
Yeah, I have done quite a few band to MGBs, and definitely there is a higher incidence of reflux in these patients. And the same is the case with sleeve to MGBs, because of the high pressure, the G junction has been compromised in these patients. And we have to be careful doing endoscopy before, doing the MGB. And if there is a hiatal hernia, if it's needs to be fixed. And again, I would do side-to-side bronze anastomosis if I'm skeptical even a bit. So these cases have to be really, we have to be careful about in these cases.
Thank you. Chetan, I'll come to you. Dr. Enrico, please go ahead.
Yeah, I'm more in the sense of the comments of Laurent, in the sense that patients actually feel much better after removing the band and doing an MGB or OAGB because of the lower pressure system. We've had patients with a diameter of 8 to 9 centimeters esophageal after the bands being there for more than 20 years. As he said, it's a pseudoachalasia we're dealing with. So if you do take care of all the fibrous scar tissues that are around the band, below the band, and you kind of make sure and guarantee that there's a good passage through the lower esophageal sphincter. And if you do this long reservoir, this long gastric pouch, these patients are better served with an MGB, and we have not had more reflux in this kind of patients compared to the others. So we don't prophylactically add a Brown's enteroenterostomy or any other kind of operation like that.
Thank you very much. Chetan, you've got the last words.
Thank you. I think very, very valid points for everyone. I think what we did not discuss here was, when we do this conversion, are they one-stage conversion or are they two-stage conversions? Because you see, I think that factor no one touched here. whether that band is in a good position, sitting nice, and you're just converting, whether that's a slip band with a big gastric pouch, because that's what we see a lot of patients with, big gastric pouch there. And as Enrique mentioned, it has been there for 10, 15 years, torturing the esophagus with dilated esophagus. I think in those ones, there is no way you can convert them to sleeve. You are only going to damage it further. In those ones, you could probably, an MGB would be a better option. So I think that's one factor, because if you look at the systematic review of revisional surgery, it does show that I think around 500 cases only reported, and it does show one stage and two stage, that yes, one stage is good, but it does have higher early complication rate compared to a two-stage procedure. So I think that's an important factor to consider when you plan band to mini gastric bypass revision.
Thank you very much. Dr. Rutledge, for final words, do you have any comments on this mini bypass surgery reflux issues?
Yes, sir. I'm afraid I'm going to get in trouble, but I think we see a paradox. And the paradox, I think, to me, was most starkly drawn in a recent article from Australia. Australia, as you recall, was a big advocate of the lap band, and now they are becoming big advocates of MGB. When I talk to patients and surgeons around the world, Australia seems to be adopting the MGB wholesale. But a recent article, I think this past month, showed that in one study of most of the data from Australia, the MGB resulted in a 10% revision rate for bile reflux. So it's possible that the MGB is a terrible cause of bile reflux. In my own mind, given my experience with Dr. Kullar's data, my own data, I think that we see different techniques resulting in different outcomes. And so I leave that there. And I mentioned one more thing. Remember that my patients now are up to 20 or 23 years post-MGB. And in addition to asking me what I think, Facebook allows you to talk to anywhere between 5,000 and 10,000 MGB patients, many of which are mine. And what I would suggest is all of us here are honorably reporting our results. I think it's interesting to talk to MGB patients who are 10, 15, and 20 years after their MGB in large numbers. And what we see is kind of what we've heard from some of the reports here is relatively low incidence of bile reflux. And I would mention one other area on Facebook. It's something called a group called it's a group called Weight Loss Surgery Ruined My Life. It's a tragic series of hundreds, now more than 1,000 patients who've had sleeve, Roux-en-Y, and are suffering from being fed through a feeding tube, losing their teeth and malnutrition. And so again, all of us are honorably trying to report our best results and our best technique of understanding those results. But also I would point out there is another option too. In addition to reading papers and things like that, you can actually talk directly with people who've had the operation. And the difference in outcomes, to finally repeat it, might be because of inaccurate reporting, but it also could be that there is fundamental differences in our technique.
Thank you very much, Dr. Rutledge, for those comments. Really appreciate them. And certainly, yes, that's one avenue that we will look at. I would like to take this opportunity to once again thank the entire panelists and to the participants who've been very active and continuously sending over questions. I think in the interest of time, we come to the end of the session. Once again, thank you very much for the opportunity. And I personally learned a lot. Thank you, Imran. Thank you, Amir, and Seal, and Professor Rutledge, Dr. Kullar, Dr. Enrico, Leani, Chetan, and Helmut for being on the board. And I miss Kamal. I think Kamal is doing some Kamal somewhere. So I hope he's well. Thank you very much, and a very good night from Singapore.
Dr. Asim, really thank you for such a moderation. I think you are one of the best moderator, and also this was in my opinion, the most important session. So really appreciable and hope from all of our panelists. So it will be great message, and I hope it is a great message, especially for youngsters. So this is the time. So we have our president. Online president of MGB OAGB International Bariatric Club, Professor Arun Prasad. Sir, over to you, sir. Message from Professor Arun Prasad. Sir Arun, can you hear me?
I don't see Arun here.
He's not in the panel, Imran. I think
Imran,
yeah,
Imran, I'm the vice president. What do you need?
Sir, welcome, sir. Because now I was chatting with Arun, so we need a message about this series. Please, sir, you can continue. Then Arun will join you. So because we have started this series in Jan 2021, and now we have 22 experts. So they contribute in this series and they share their experience. We had a lot of questions, and also they share their experience. So what was our target in this COVID era? So we used this way of online and to convey the message of these experts to youngsters and to all over the world. So in this panel, in this overall experts, we had from USA, from Italy, from Portugal, from Spain, from Pakistan, from India, from UK, from all over the world. So from Egypt. So just a message about this series. So we will hopefully Arun will also join us. Please, sir.
Well, as someone said before, this has been probably one of the most scrutinized operations in bariatric surgery. And these, I think, instead of weakening us or weakening the operation, has made it stronger. This type of meetings or this type of events, of course, make it stronger. There are a lot of controversial issues that need to be dealt with and need to be known. One of the main issues is that we've tried to convey both in the mini gastric and the OAGB, the one anastomosis gastric bypass, is the need to standardize the procedure. We now have a lot of hybrid techniques from different surgeons. You divided the group in MGB, OAGB, and hybrid. And one of the most important things to do is when we publish is to specifically address the technique we're using. If you're using a hybrid procedure, emphasize what you are doing in each step of the operation. So that would be my message. Your contribution, your efforts are very, very good and have strengthened our operation a great deal.
Sir, so thanks. I think Professor Arun Prasad, he's online with us. Professor Arun Prasad is now president of MGB OAGB International Club. So, so please, sir, your message for this series and this session.
Thank you, and congratulations for having conducted this excellent series and bringing everybody together during the pandemic. So on behalf of the International MGB OAGB Club, I formally congratulate you, all the faculty who have participated, and all the delegates who have attended this series, as well as the grand finale today. I hope everyone is a member of the International MGB OAGB Club, which has done a lot to bring together all the MGB OAGB surgeons from across the world. We were hoping to hold the international meet in New Delhi, India last year, but that had to be postponed due to the pandemic. Hopefully, if things are all right, next year, I would like to hold it in India and perhaps invite all of you to come there, be part of the meeting physically, as well as enjoy the hospitality, and we can get together and share a drink. So Dr. Leani is smiling at my invitation of the drink. So Laurent, we look forward to meeting everyone. And with those words, I would like to hand you all back to Imran. Over to you, Imran.
Sir, really appreciable. I know now this in India also little late, but again, so following till this time, and this all is due to all support of all of you, especially personally, you have supported this series, and with your support and guidance, now we are sitting here, and this is a final sum up session. Sir, so much thanks, and again, we need your support, and hopefully in future we will continue such an activities, and with the help of Chetan and Professor Kamal Mehvar, we will be able to write this activity. So especially 22 experts of MGB, OAGB, and also we will create such a questionnaire. And again, I will disturb you and hope with the guidance of Chetan and Kamal Mehvar, we will be able to write something for youngsters and new generation. Thank you, sir. So now, because this is only 5 minutes break, then we will continue our next session. 6 minutes. So just you can take a cup of tea or coffee. Then Tansir will be moderator and he will continue, and we will try our best to close within next 30 minutes. So this series was so sponsored by a full exclusive sponsor was our Easy Surge Global Trading Limited. Easy Surge Global Trading Global. So I will share a short video. This is the video. Just a minute. Okay. Yeah. Okay. Just a minute.
Shanghai, the most progressive city in China, a global center for cutting-edge science and technology. In 2011, Easy Surge Medical was born here. Technical innovation has ensured Easy Surge's leading position in promoting new techniques from minimal invasive surgery. Our R&D team is committed to exploring better solutions, creating clinical value, focusing on details, and ensuring very high technology. Every time a key obstacle is overcome, we realized a breakthrough in minimal invasive surgery medical device. In Shanghai and Suzhou, Easy Surge's 2 large production facilities are beginning to take shape. Clearance at GMP 100,000 grade, automated production lines, and a system for lean manufacturing, and efficient quality management system have laid the cornerstone for the outstanding quality. High-quality surgical devices invasive surgical equipment, we have created our very own self-reliant premium brand. To ensure that innovation never stops, EasySurg has created its own unique knowledge database model for product design. Through in-depth discussion with clinical professionals, we have explored new directions in medical technology and devised ingenious solutions in collaboration with a host of engineers and technical experts. Together, we have created valuable innovations that are leading the way in minimally invasive surgical techniques, and we continue to promote their development in order to ensure patients' quality of life post-surgery. EasySurg is vying for success in the market for exclusive medical devices. The company has already been recognized as a National High-Tech Enterprise, a Brand Cultivation Showcase Enterprise by NIIT, and a Shanghai Brand Cultivation Showcase Enterprise, and a Specialist Enterprise in Shanghai. EasySurg Medical holds numerous patents. A heart of virtue. We are striving to achieve our goal of providing patients with affordable, high-quality, minimally invasive surgical devices. EasySurg Medical will continue its work in technical innovation and industrialization of premium medical devices, assisting in creation of Shanghai Center of Technical Innovation, and creating a respectable, exclusive brand for global minimally invasive surgical products. We aim to be an influential participant in the international market and to help surgeons and patients throughout the world.
So again, welcome really, and now we can go ahead with the next session. So now this is the time to continue our next session. Dr. Tansir Asghar. He is well-known bariatric surgeon and consultant bariatric surgeon in Islamabad, Pakistan, with a lot of experience in bariatric surgery. He is also managing director of GLR, Global Laparoscopy and Robotics. Tansir, over to you.
Thank you very much, Dr. Imran. It is a privilege to be among the galaxy of surgeons and experts in bariatric surgery all over the world. Following the series of interviews and sessions with about 22 great surgeons, bariatric surgeons of the world, today is the sum up session. I would like to thank all the panelists and the moderators in the session who have participated in the sum up session. It is a great learning experience, no doubt, not just for the young surgeons, but all the surgeons who are even experienced. They are gaining knowledge and experience from all the other experts all around the world. There were great sessions moderated by Ariel and Asim Shabir, and we learned a lot, and there was a very healthy discussion. Now, in this session, I would like to put on 3 to 4 questions from the experts of bariatric surgery over here, which is more related to the MGB and OAGB things. So the first question would be, do you measure the total small bowel length in patients undergoing primary or revisional MGB or OAGB surgeries? I would like Dr. Kolar to say something about it.
Nice to see you, Dr. Tansir. Thank you very much. If I'm going up to 250 centimeters, then I don't look at the distal bowel. If I'm going beyond that, then what I exactly do is I run the distal part of the bowel, and grossly, it takes 2 to 3 minutes if you just run the distal part of the bowel. I don't have to exactly measure how much is it, but I see if it's more than 300 centimeters, it's good. Then I don't go beyond that.
Okay, it means that you usually, you often go beyond 200 centimeters, right?
Not very often, but in
Okay.
selected cases, like super obese
In which,
patients.
if I would ask, in which patients, what are your criteria for that, going to 250 centimeters or beyond?
Super obese patients, where the
Infidels.
BMI goes beyond, 60 BMI and above.
So do you see some malnutrition or other complications in these patients who you pass the 250 or 300 centimeter line?
Yeah, definitely. When we do a longer bypass, the chances of hypoproteinemia are always there, and the incidence definitely increases. It goes to 2 to 3% when we go beyond 250 centimeters.
Okay, that's great. So what do you think is the ideal length you take in MGB and OAGB patients?
But the problem is, see, if I do a super obese patient with a BMI of 60, 65, and I give him I have tried all these permutation combinations, and I have to say that definitely the length matters. And these patients deserve longer lengths, because otherwise they don't get good results. So if a patient with a BMI of 60, 65, if he's 180 kilos, comes down to 130 kilos and stops, and then starts gaining weight after 3 years, so it's not a good result. So these patients need longer lengths, but they have to be informed very well that you got a stronger procedure and you have to be more watchful, but the chances are only 2 to 3%. So it's, otherwise for super obese patients, their chances of dying with other problems are much more. So they are ready to take that risk, but they have to be, made aware about that. And we need some closer monitoring for these patients. And so long as we are within the jejunum, all these patients do very well. There is no reason why they have a low protein, except that sometimes if my designing has not been good, there is a stricture or there is a twist of the gastric tube. In those cases, patients not able to eat properly, definitely those patients can go into hypoproteinemia, even with a 150 centimeter BP limb. But definitely, I believe the length does matter.
That's great. I think Dr. Rutledge is not online, but as far as I remember, he used to say that all the patients should have a wider gastric pouch and the length should be 150 centimeters. He has worked a lot with you. What do you think his technique about MGB?
Oh, his initial paper, which was published in 2002, that said that his technique used 180 centimeters of the BP limb, but he has been customizing the BP limb quite often, and he is very clearly of the opinion that length has to be varied according to the BMI and according to the metabolic factors involved in the case. Like, we are very clear that if the patient is an old diabetic with a relatively lower C-peptide close to 1, these patients need longer lengths. Otherwise, they don't get good results. So now Rutledge tailors the limb. In every case, yeah.
Thank you very much. I would request Dr. De Leon and Craig Glico De Leon to put some light on it.
Yeah, hello again.
Thank you.
So a little bit of the history. When Miguel Carvajo started doing the operation, the OAGB, he used to only bypass 2 fixed meters, as the MGB suggested. The results were that many of the patients were not losing all the weight that was needed. And some of these patients that we followed up for a long time, these patients that were reported in 2005, have required a reoperation due to weight loss failure or regaining. So after these 2 years, he decided to start counting all the small bowel, the whole small bowel. And the technique that we've shown in many videos, to make it easier, we add a further 5 millimeter trocar in the right lower quadrant in order to count from the right side of the patient and follow the root of the mesentery down. And we also suggest tilting the table, both the head and also into the sides when this is needed. So that makes it much easier. And actually, the time that is needed is 10 minutes, to count the whole small bowel from the Treitz ligament to the ileocecal bulb. Once we do that, that's the first parameter we have in order to decide how much bowel is going to be bypassed. The other parameters, as you know, of course, the weight, the excess weight of the patient. It's not the same to be operating on a diabetic who only has 15 kilos of overweight and will benefit from the operation, of course, from the metabolic standpoint, to a patient that has, a BMI of 75 or 80 that we do operate. So that's one of the parameters. The other one is the age. As you know, younger patients tend to adapt in their small bowel capacity of absorption much more than the older patients. So it's not the same to be operating on a 15-year-old and a 75-year-old, which we have operated. In fact, we have a case report that we published on a 12-year-old that had a 65 BMI, was hypertensive, had diabetes, and the publication came when he was 17, fully grown up, and this was an aggressive bypass that we use in this young patient. So these three parameters are probably the main ones. There are some others, of course, the metabolic standpoint, like I said, but this leads us, to make a decision. We published also a paper where BMI of 25 was the goal, and found out that in Miguel's series, I want to stress this because the patients in Spain are different from the patients in India, even from the patients in Mexico, of course, the United States. So in Spanish patients with a good income, that have the capability of eating good food, proteinous food, we found that bypassing 60% of the total small bowel would lead in the long term to this goal of maintaining them in a 25 BMI. This is something that was published. There's a lot of statistics in this paper that you may be able to read. So I here would like to emphasize that maybe what is found in this suggestion of 60 biliopancreatic lymph, 60% to 40% in common channel, would not be benefiting all patients in the world. And actually, in the discussion of that paper, I myself added a paragraph saying that this had to be considered with all the things that the patient itself has in an integral basis. So the compromise that the patient is doing with you and the responsibility that you are taking with the patient and the patient with you is very important. If you are not going to follow strictly these patients, I do not advise this aggressive bypassing of the patients because you're going to be in trouble. And we've had patients with hypoalbuminemia, patients with anemia, with these longer bypasses. So that's what I'd like to say. If you have a very strict program where you follow up the patients, where you have the compromise that they're going to have the money to buy the supplements that you may have to be giving them for at least a year, once the common channel adapts to the absorption of protein, then you can easily or with more guaranteeing, you can do these kind of operations. And why are we trying to be more aggressive? Because and you all know that obesity is a chronic progressive disease, and we're trying to find the solution to give these patients a substantial and long-term weight loss, and not being needing any reoperations in the future. That's what I would have to say.
That's great. Thank you very much. My other question would be, what are your thoughts in tailoring BP limb to improve outcomes of metabolic and bariatric surgery?
Tansir, I want to share some videos regarding this, tailored BP limb.
It is very important question.
Yeah.
Tailoring limb. We should see the videos first, and then we'll discuss it.
Sure. Just I will share. So can you see this?
Yes.
Okay.
I think because the patient is asked for weight loss resolution comorbidity, and from literature and my experience, we want to bypass as long as possible. And it should be BP limb, not elementary limb. However, at the same time, we need to preserve enough common channel. So I think the best policy now I read the literature varies from the whole bowel length from 30% to 50%. Yes. So you have two options to do. First, you can fix the BP limb, but you need to increase in super morbid obesity because they already have randomized trial. And you need to increase in diabetes patient because it's important for them. And also you need to increase in revision surgery because we know this group of patients is difficult to lose weight. So you can have your principle now to increase the BP limb as you like. For me, I will always measure bowel limbs, and I will bypass 30% to 40%, depends on the patient. If a primary surgery, no significant comorbidity, 30% for me is enough. But if the patient is diabetic patient, super patient, and revision surgery, I will extend to 40%, even to 50%. But I will always make sure I have at least 4 meters on distal. So this is my principle, yes.
So Tansir, I will check if I have another video, just I will try to, so I will see, because it will be, also we can take this. So can you see now?
And
yes.
Patients, we have been operating for the last 5 years. Strict policies that patients are below BMI of 45, we do 1.5 meter. Below 55, we do 1.8 meter. Above 60, we make sure that we have at least 3.5 meters common channel, and we do about 2 to 2.5 meters. We are doing fine unless the patient is coming admitting that he's not been buying his supplements, he stopped taking them for whatever reason, financial or behavioral. So these patients, if they are admitted and we know that they had the surgery in our center, and we go back to our notes and we know that the measurements was done properly, we can supplement them back conservatively, and they go back to good nutrition without further surgical intervention.
Please, Tansir, over to you.
Thank you, Imran. I would like to request Helmut Billy to share about the tailoring of BP limb to improve the outcomes of metabolic patients.
Well, I'll say that my experience with mini bypass caused me to increase the length of my BP limb in gastric bypass. And surprisingly, we're seeing lots of discussions about that in the United States, where many, many famous surgeons that, if I name them, you'd know them all, have increased their BP limbs to 80, 90, 100 centimeters
Granted, they're being cautious, but this all comes from the data on the MGB, even if they won't say that. One of my areas that I like to bring up a lot is how we actually measure. Because if you're measuring in what you think are 5 centimeter increments, but they're actually 10, your 200 centimeter BP limb is actually now 400. And we have not, as a society, in any of the countries, come up with a way of measuring accurately that is confidently reproducible between each surgeon. And I bring this up because we had one case of severe malnutrition after MGB. And when we brought the patient to the OR, I measured the BP limb, my colleague measured the BP limb, and both of us came up that the BP limb was 500 centimeters. Then we measured the distal, and we had about a 200 centimeter distal common channel. And so I do think that it is essential to measure the distal channel, at least getting to 300 or 350 centimeters. You don't have to measure the whole length, but you have to be confident that what you have not done is erroneously made your BP limb longer than you thought, and then leave the patient with inadequate common channel. It's so easy. It only takes a few minutes to check. And until we actually know how we all agree measurements should be made, I made the comment to Intuitive that on the robotic platform, it's actually almost impossible to measure anything very accurately because the wristed instruments have no markings. And once you move a wrist, the measurement is now altered. So whether we're going to use tapes, whether we're going to use markings on our instruments, I think this has to be an essential discussion when we're talking about what a limb length should be, because I bet we all do it differently right now.
True. From your suggestion, from your talk, I can say that you advocate the measuring of whole bowel.
No, I create my limb first, and before I actually complete the anastomosis for what I think my BP limb will be. So I will use some sutures like Carvalho has done. I'll run a 5 centimeter, 6 centimeter running suture to approximate the pouch to the small bowel, and then I will measure. And distal measurement, once I hit 300, 350 centimeters, I stop. I don't measure the whole length.
You don't measure the whole length. And secondly, do you favor that tailoring the BP limb gives benefit to the patient depending upon the BMI of the patient?
Yes, I do. I actually think this topic will probably evolve into measuring the total bowel length and determining a percentage, so that we are really not having to worry about how we measured the length, but take the percentage of what we measured and try to make the limb accordingly. That is probably the future of how we will develop a standardized technique.
Okay.
Can I add something there?
Yeah, sure, please.
We don't see it as the future. We've done it. We've been doing this for years. I think I agree that everyone measures differently, and measuring the whole small bowel and taking percentages can deal with this divergence in the way we measure. So if you say your 10 centimeters are really 5 or 6 and mine are 3 or whatever, taking percentages of the whole small bowel can deal with this problem. So we've been doing this for many years, and the technique we use, as I have stressed throughout this morning, by measuring from the right side of the patient, it actually makes it more easier and less risky. Because when I ask surgeons why they don't measure the whole small bowel, most of the time the answers are, it is time consuming, it is risky. I've in the articles and chapters we've written, I've said that probably these 10 or at the most 15 minutes of the operation, which I must also say that is the first part of our operation. We do this before anything, and I've put in these chapters that these are the best minutes invested in this operation and in this patient.
Can I just say one word, please? A question.
Yeah,
one
sure.
quick question. I ultimately agree entirely with Helmut. and I always believe what Enrique and Miguel of the percentage of bowel length is something we need to do. I mean, at the end of the day, this is, I think, what we're going to do. But I just have one question to you, Enrique. Is interesting is, okay, in the past, you used to bypass 200 centimeter from your mini gastric bypass, then you changed to 60-40 or perhaps 50-50. What I would like to know is, since you have changed to a percentage comparing to a fixed bypass at 200, do you see in this, since you've done this, do you see less malnutrition than before?
No, I think there is more malnutrition. That's
right.
That's a fact. You know, if you want to play it safe, then you can do as in the UK, many surgeons are doing, in bypassing only 1.5 fixed meters and not counting the whole thing. Even then, you may recall this paper from, I think it was Iran, which at necropsy after fatal malnutrition, they found that the patient only had, I think, 3.2 meters of the whole small bowel. So you know,
to continue to continue in this thinking, don't you think it will make somehow some sense for all of us to in fact count from the ileocecal a distance which would say, okay, 3.5, Helmut is here, he's listening to me, let's say, and then say to ourselves, this is what we need, and that's it, and bypass the patient there.
No,
so,
that's you are describing.
It's just a question.
You are describing this saggy, what they, you know, which I don't agree of bringing more names to this problem or these operations. But the saggy, actually, that's what they do. They start from the ileocecal bulb and count upwards and don't count the whole small bowel. I think that once you do it in a standard fashion, it doesn't take a long time. It's not risky. I have not had any complications from counting the whole small bowel. And also, sometimes you find things in the small bowel that may lead you to change the operation, or even, you know, Meckel's diverticula, some other stuff. So we do suggest and recommend highly the whole counting of the small bowel. Whether you bypass more or less, I think depends on the type of patient that you have, the type of compromise, the type of financial situation of the patient. You know, if you don't want to risk it, then go to the less aggressive hypoabsorption in these patients. You know, I've been practicing both public and private practice here in Mexico. I have not had problems in the private sector with the hypoabsorption, but I have had many in the public sector. So, you know, that's another parameter that we should probably be taking into account.
But if you take a...
Okay, please, Laurent.
No, but if you, so just to finalize this idea, this concept, if you basically, and I agree, come to a percentage bypass concept for the patient, it doesn't prevent you to at least have in count, then you need to have a substantial amount of small bowel distally. Do you understand my point?
Yes, and for this,
this is important for who is listening to us, because even if they do 50-50 or 40-60 or 60-40, if you don't have at least 3 meter or 3.5 below, you put yourself in a shit.
I think, you know, to answer this question, you are all digestive surgeons also. So, and we know that the degree of hypoabsorption or malabsorption that we create in operations is not equal to the degree of malnutrition. You've done many small bowel resections for other reasons. And you know, you can keep, I have patients with 1 meter of small bowel. And if you keep the ileocecal bulb, this meter readapts And these patients are eating the same that you're eating now, or myself, with 1 meter. So I think the degree of hypoabsorption is not always equal to the degree of malnutrition. There are many other factors that, the variability of the human being and the way they behave after the operation lead to the final results.
Sir, I have just a comment here, Tansir, I have just a comment here, because this tailored BP limb is, in my opinion, is another one of the important point in MGB. So we have a question from Surendra Ogale. Sir, Surendra Ogale, are you live? Surendra Ogale, can you hear me?
Yes, Imran.
Sir, how are you, sir?
Fine, thank you.
It's a great honor. So because just I read your question, so it was great opportunity for me to take such a legend online. Sir, please, this is time. So because this is, in my opinion, your question is very important. Just Laurent also highlight this, because this common channel is very important. When we, this formula 60-40, okay, when there is the bowel length is 300 centimeter, 400 centimeter, so then what will we do? So sir, please, if you have any comment.
So what I'd like to point out is that we find, after doing all these different procedures in bariatric surgery, whether it's MGB of 150 or 200, whether we have done SASI with 300 from ileocecal valve, or SASI from 350 and 400 from ileocecal valve, you find so much of variation. Now, there are some patients in the same environment in India who eat probably similar types of food, and they are able to handle an anastomosis which is at 300 centimeters from ileocecal valve, or even 250 centimeters. While there are some others who have shown up with nutritional cirrhosis, who have had so much of malabsorption that we have had to actually disconnect the anastomosis. So one of the advantages we found with this operation of the loop bipartition is that if you disconnect, you at least have a sleeve in place, and you can avoid the excessive malabsorption that is there. So we have even shifted to a more proximal anastomosis. It's like doing a sleeve with a gastrojejunostomy at 200 centimeters. So like one of our colleagues said, this is like doing an MGB on a sleeve. We find that worldwide, most surgeons are most comfortable with a sleeve. And many surgeons have become very comfortable with a loop anastomosis, one anastomosis. So if you do a sleeve and a gastrojejunostomy at 200 centimeters, we find that most of the people are fine, they accept this really well. But in every case, we are measuring the whole length of the bowel, because as everyone has said, every now and then, you sometimes have rarely 350 centimeters of total small bowel, and it goes up to 1100 or 1200 centimeters small bowel also. The average small bowel, since we measure in every patient of our metabolic surgery, with the ileal interposition or with any of the bariatric surgeries, we find the average length is 600 to 700 centimeters. But the point is, we must also learn from others. Like Dr. Lee mentioned earlier, how he has graduated over the years, where earlier he had a certain length of the bowel, then he tailored it, and now since 2016, he's making sure that 400 centimeters of the common channel is left over there. So this is saying something. That means he obviously has experienced and come across a lot of problems when it was less. So I think we should take heed of all this, And if we as skillful GI surgeons, if we cannot safely measure a small bowel with good, bowel graspers, and a reasonably easy way like we do it is our graspers have a mark at 10 centimeters in both the hands. So you can swiftly move them, and as long as you are sensitive to the movement of the bowel, you can safely measure. So I don't think we as bariatric surgeons can make excuses that we cannot measure the small bowel safely. I think we are way past that. If we want to do safe surgery for our patients and prevent all these complications, I think the prerequisite for any bypass surgery should be measurement of the whole small bowel, and then you decide how much of bypass you want to do.
Thank you, sir.
Saran, it's wonderful to hear from you, but and everything you say, it was great, but you didn't answer the question. It was wonderful. You can compare MGB with a SASI, and on top of this, as much as I agree with everything you say, you didn't answer the question about what do you think is the bowel length on MGB. You don't compare the MGB with a SASI.
Okay. So are you asking about a safe bypass length for an MGB?
No. Well, yes, because I mean this was the original question.
Okay, so I would again say you measure the whole small bowel. If your bowel is 600 centimeters or more, you can do a anastomosis at MGB of 200 centimeters very safely.
Okay.
If the bowel is shorter than that, it might be better to do it at 150 centimeters.
Okay.
So that would be my answer.
So Dr. Shweta Ugal, from your talk, we have learned that measuring the whole bowel length is important, and then almost 1/3 of the bowel should be bypassed. This is your take-home message, right?
Yeah. Yes, don't bypass more than 1/3. And like Dr. Lee also said, he does for his standard MGB is 30%. So I think that fits in with the same.
Which is fine.
Yeah.
That's great. So the take-home message from Dr. Ugal is that measure the whole bowel length and 1/3 bypass.
And common channel. Common
channel should not be less than 300 centimeters, right?
I would say 400 for our environment. 400. Now, like they said in Spain and other places where people can manage to eat more nutrient-dense food or more high-protein food, they can manage greater lengths of bypass. But in our setting, I think 400 centimeters of the common channel, just like Dr. Lee's experience, is the same as ours, would be very safe.
That's great. Thank you very much, Dr. Ugal. I can see Dr. Ghulam Siddiq in the panel group. Dr. Ghulam Siddiq, can you tell us that what are your thoughts about the tailoring of BP limb to improve the outcome of patients?
Thank you very much, Tansir. Actually, I think BP limb is so important, and I agree with most of the speakers, though I joined a bit late, that measuring the total bowel length is very important. I have come across a few cases of Roux-en-Y gastric bypass where I didn't get the required result. And I think this is the right time that we measure the total bowel length even for Roux-en-Y gastric bypass as well. I think as a matter of principle, 30% of the bowel should be bypassed. You need common channel of at least 3 meters. I recently did a young girl who has had a bypass done outside Pakistan. And that bypass, I couldn't understand. She had severe malabsorption. And when I went in, she had a BP limb of 3 meters, Roux limb of 2 meters, and the common channel of 90 centimeters.
Okay.
Would you believe it?
then definitely she would be having malnutrition.
I tell you that the girl's BMI pre-operatively was 40. And when she came to us, the BMI was 20.
Oh.
Now,
Okay.
this was a wrong selection of cases, of a case where she ended up with severe malabsorption. I operated on her, and luckily, it's now almost 2 weeks. She's doing very well. I think these are sort of cases, if we measure the whole bowel length, I think cases, particularly in MGB or Roux-en-Y, in both cases, you won't have, excuse me, you won't have failures. I also agree that people do patient to patient, there are variations. The same type of food, the same type of procedure for the same patients population, they have different results. But by and large, I think we should measure the total bowel length.
Okay.
Can I say something here?
Please, sir.
Now,
Yeah, sure.
from what we heard from him, if the BP limb was 300 centimeters and the alimentary limb was 200, he said, right?
Yes, true.
500. Now, where in the world is anybody, taught to do something like this? I mean, this is outrageous. It will cause so much of harm to our all the credibility that we have as bariatric surgeons.
I think the whole idea of doing these conferences and these meetings is that we don't want to see such type of procedures being done by people who claim to be bariatric surgeons.
Yes.
Certainly, this was a plain gastric bypass. It was nothing else. They had a small gastric pouch, which was perfectly normal, and but it was just the wrong case selection. Maybe if somebody had a BMI of 80, and if he would have done that, one would have said, okay, fair enough, but not in somebody whose BMI is 40.
No, but nobody in the world would need to do a procedure with these limb lengths. I don't think anyone in the world it has been taught. So this is a maverick surgeon who's doing something that is completely out of the box.
Exactly.
Most likely, they didn't measure total bowel length.
Yeah.
Definite, sir.
So the take-home message
No, but
from
even
Dr.
if-
Ghulam Sadiq.
No, even if you don't measure the bowel length, but doing a 300 centimeter BP limb and then 200 centimeter alimentary.
So, sir, sometime as Helmet, if you remember, Helmet highlighted. So this measuring is very important. Maybe when he measured, so that was wrong way of measuring. So he measured about himself 150 or 100. So, but maybe this, so as you have mentioned, so we must measure accurate and whole bowel length. Then there is less chance of such a disaster, I can ask, unfortunately.
Imran, the thing is, if you are so close to the ileocecal junction, that's about 90 centimeters, I don't think it was wrong measuring. I think it was all intentional.
Heroic surgery.
Yeah.
Yes, sir.
Thank you very much, Dr. Ghulam Sadiq. Thank you so much. Dr. Ghulam Sadiq is consultant bariatric surgeon at Shifa National Hospital, Islamabad, Pakistan. And he is also president of Pakistan Society for Metabolic and Bariatric Surgery, Islamabad and KPK chapter. And he has a vast experience in sleeve gastrectomies, Roux-en-Y gastric bypass, and OAGB. It was an honor to have you, sir, here. Now, my last question, which you have already answered a bit, Dr. Ghulam Sadiq, that have you ever come across extreme weight loss in MGB, OAGB patient? And which is your preferred approach to prevent and manage these issues? So Dr. Ghulam Sadiq has already told. If anybody else has any experience on it, let's have a small talk on it, because we are already running short of time and we must conclude this session. Dr. Ariel, do you have something to say?
Sir Enrique, can you mention this? Have you faced weight loss, especially because you are doing so little aggressive OAGB?
Yeah, as far as prevention, very, very short, is the things that I told, the compromise of the patient to your group, and of course the surgeon to the patient, the financial issues, the capability of eating proteinous food and buying supplements, and of course the strict follow-up in these patients. This will prevent many of the issues that we've discussed. If you do have a patient that has hypoalbuminemia, your best, I mean, the first step is to reverse this hypoalbuminemia. And sometimes we've been able to reverse it, you know, as the only step by hospitalizing the patient, giving them total TPN and all the supplements that they need. Of course, when you do that, I always stress the patients that besides the TPN, they should keep trying to adapt this common channel that needs to be adapted. And so we give them enterotrophic amino acids like glutamine or others that you will know. And then some of the patients do need a reoperation, and the types of reoperations that you can do range from reversing the operation completely, which the ones I've done 2 patients, and the reversion, of course, led them to be obese again, hypertensive, diabetic. So we discussed that with the patients, and reversion actually is a little harder than with MGB because of the nature of our anastomosis. We do a lateral, and then in the MGB, you know, it's a terminal lateral, which Dr. Rutledge has shown that he can only just staple that anastomosis and then do a gastro anastomosis. So sometimes we, because of the nature of this lateral anastomosis, if we do that, I've had a patient that we caused a stricture in the small bowel. So if you're gonna reverse here, you have to cut both limbs and then anastomose them again. Now we do have another operation where what we do is we cut in order to lengthen the common channel, we leave kind of a cuff of small bowel from the efferent limb, the common channel limb, and then do an entero anastomosis between the 2 limbs, and then run the bowel to give them more common channel. And you can do that also in the other way if you have weight loss failure, and give them a shorter common channel. And at the end, we anastomose this cuff that we left from the efferent limb, the common channel, to wherever you want to do this anastomosis. That would be one thing that we're currently doing for these types of patients as far as the alternatives of surgical revision.
Thank you, everyone.
Enrique, I think the message for everyone, and not just us, but people is watching, in this kind of patient, I believe if you do have to, if you have patients with hypoalbuminemia, hospitalization, correction of the albumin, as a mild ascites, my advice is to reverse the patient. That's it.
That's great. So the take-home message.
I mean, Suran, I'm sure you agree with me. You just reverse the patient, save the patient's life, then we will see.
Completely, you mean? Reverse completely?
Yeah, you reverse, you just disconnect. It's very easy. I mean, quite frankly, you just do it, you divide. I think this kind of patient, it's very rare, but I will not embark myself to any fancy, they have already immunocompromisations, they're doing more anastomosis, it's can increase the leak rate, and just reverse the patient and then we'll see.
So you would reverse in the setting of hypoalbuminemia before optimizing the patient?
No, I will exactly do what you do. The truth of the matter is I have been involved with one patient of my friend in Paris long time ago. I have never seen one of this so far. But nevertheless, if you look at what to do in this very difficult situation where the patient is extremely malnourished, with bilateral legs edema, with mild aside, I mean, with everything you know and I know, you correct, if you can correct the patient electrolyte and albumin, operation for operation, I will advise the patient to have a reversal.
Thank you,
I
Tansir, we have
So the
live, Tansir, can you
the
hear me?
patient and reverse the patient.
No, you
Yeah,
reverse the
I
patient
can.
to normal anatomy.
Yeah, we will optimize the patient, reverse it. Okay, thank you.
Yes, yes.
Yeah.
Tansir,
Yes,
we
Dr.
have
Imran.
live now. We have live now Professor Karl from Germany. He want to comment on this. So Karl, highly welcome. So what is your opinion about severe weight loss or malnutrition after MGB, and how you will manage surgically? Please, Karl.
Good evening, everybody. In these cases, actually, of course, we check for the nutritional state, and sometimes if the protein is too low, we would have some nutritional treatment first via central line, getting up the protein, and then only then going for reoperation. And reoperation, I think you must see the whole situation of the patient. I wouldn't go for complete reversal at every patient. I would check for the bowel length, for the limb length, and depending on the state, going either for shortening of the bypass, or for reversal. That depends on the individual situation. I think there is no only good way. It's both is possible. Either reversal, of course, it's the safest in severe cases. But if really there is like too long BP limb, too short common channel, you can also go for shortening of the BP limb.
But if you do this, Carl, what you're going to face to yourself, you're going to short the pouch, you're going to have a much shorter pouch, and you can put yourself in a very difficult situation.
No, I don't shorten the pouch. No, there's no pouch shortening. In these cases, we just cut off the anastomosis with one 60 millimeter cartridge. There is no loss. There's just one cartridge to undo the anastomosis, and it's to redo. It's just like a primary MGB.
But Carl, just doing this, you're going to anatomically, systematically shorten the pouch. You're going to shoot the gastrogage with a stapler, and then you're going to go above. Right?
It's perhaps 2 millimeters, 3 millimeters of loss, but not more. You do pouches like 20 centimeters of length, and if I go with one stapler, with one cartridge across the anastomosis, there is no shortening, never more than 1 centimeter. It's
that's okay.
Laurent, in order to deal with this, we don't touch the anastomosis. What we do is we give.
You are different, Enrique. You do. Yes. I know exactly what you do. Believe me, I understand what you do, because it took me some time to understood. But you are in a unique situation.
Okay.
You have a free. You keep a free jejunal flap, basically.
In a way, yeah. We lengthen. In fact, we lengthen the gastric pouch with small bowel. That's what we do.
Yeah.
Okay. So. Thank you, Dr. Karl. We are running a bit short of time. So what we can conclude from this healthy discussion is that it is better to measure the whole bowel length, and we should have a tailored approach of the BP limb. And as Dr. Laurent and others have said, that it should not be more than 1/3 of the total bowel length. That's about 5%, and the common challenge should be around 33 across a patient who has severe malnutrition. It is better to optimize the patient and reverse it to the normal anatomy, and then we'll see later what to do. And if it is not severe malnourishment, then you can just shorten the BP limb. So thank you so much, all of you, and joining here at this time in different zones of the world. I will give back to Dr. Imran Abbas to continue the later on things. Thank you very much.
Thanks, Tansir. So as you have mentioned, we already are little late, unfortunately, but because this was very healthy discussion, and every question is very important, because as you know better than me, MGB is no doubt overall bariatric surgery is still in evolution, but unfortunately MGB at the hit list. But with the passage of time, so we can see the, so this is going to popular surgery. So yes, because already we are little late, so I will postpone my session. Inshallah, next time we will discuss. So now this is the time I will invite Dr. Mubashir Iftikhar from Malaysia, because you are our legend. So you surgeons, really it is great honor. So you are live till this time. So we have also another product, GLR e-book. So again, we need your support. So Professor Mubashir, over to you. We are excited to hear from your side. So what is this e-book?
Yes. Assalamu alaikum wa rahmatullahi wa barakatuh. Very good morning, good afternoon, and good evening to all of you. I'm really delighted to be among the best surgeons. I think you all are so great, and it's really an honor to hear you. I was myself a medical doctor, turned into IT. I left my surgical master's program in third year to turn to IT, and last 17 years I'm in IT. I was the head of IT for the largest private healthcare practice in Malaysia for 8 years, and I was the chief digital transformation officer. Now I run a small IT company here. We focus in healthcare and in healthcare IT and hospital related projects, EMR, EHR, and web portals. And we recently have developed a system of undergraduate and postgraduate exams for a university hospital here, and I had an opportunity to discuss a project with Dr. Imran Abbas related to launching an e-book for GLR. So basically, let me go through, because it's short time, that as we all know, that the knowledge has become a explosion, and the data and information has become vast. So to handle this type of knowledge, we certainly need some new ways, and digital is the way to do. And like we have, as I have been running these programs with the universities, and we have recently launched a postgraduate program in cardiothoracic surgery, first of its kind in Malaysia, which is completely digital with zero paper in it. All the logbooks, evaluations are all catered through the digital platform. So this particular discussion with Dr. Imran, that we want a GLR book, and while listening all these few hours of discussion, I think absolutely a GLR book, a digital book, will help create a platform where these discussions are always available. Anytime, anywhere, one can access these information and then can go through those, and then maybe even when you are listening a discussion or you're reading a topic, you can comment about it, and your fellow colleagues can talk about it and share the information. And then especially those students, you are experts, maybe those and fresh graduates or maybe fresh surgeons who are in the field, they can learn through the experience of surgeons like you to better cope with the practice and do better. So we have basically discussed this with Dr. Imran. I had discussed this with Dr. Imran, and we thought probably we need a digital book. So basically, we are sort of subject matter experts in this, in running a digital platform for universities. And we have developed this on a reliable, secure platform, regularly updated and evolving. So basically information will be like socially shared among the authors. I'll go through that in detail. And so these are the features: a digital platform, a book.
Flights to.
So able to create chapters in it. So basically the admin will create chapters, and chapters will include topics. So there'll be like each chapter may have 5, 6, 10, 12, what number admin wants to continue adding topics. And these topics will be basically available to first authors. Authors will basically write about these topics. And once admin has reviewed, and maybe they have a syndication on these topics, once they agree, they will publish these topics, and students will be able to read these topics, able to give, and then students can have these as free or maybe paid service, which is yet to be discussed. And able to comment. Syndicate means students, when they read, or maybe the fellow colleagues or other surgeons who read these topics, they can basically comment on those, and those can be syndicated as well. Once the comments are reviewed by the author itself and the admin itself and approved to be published, these comments will be visible to the readers and the students. Able to request one-on-one sessions with the authors. So maybe somebody has published a topic, and then there are students or there are other fellow surgeons who want to have a direct session with the surgeon to discuss in more or learn from the author itself. So there will be a sort of a proper timetable available to the authors. They will say, okay, I'm available on this time if somebody requests, and then all of this will be available on the platform. So, and even the discussion will go through the platform along with the book. So these are the features for the authors. They receive an invitation from the GLR admin to write on the topic. Topics are based on the chapters, and one topic can be written by multiple authors. So like there can be few authors writing the same topic, and is able to add text, images, and videos. So we'll provide tools whereby there is available text, and then this text can be added with the images, and basically surgeons can either send through email or they can write themselves in the digital platform which we have developed. And then admin will basically nicely make those final and publish into the book. Book will be just like you are reading on the phone, something or any book you read, but this will be like with the images and videos. Authors will moderate the comments written by the readers and students, and publish or decline those comments. And it is dependent on the admins. They can allow or disallow the sessions with the readers. Like if some authors want to have sessions with the students or the other fellow colleagues to discuss these procedures, which they have given some tips, tricks, or shared some videos, shared some detail about topic or images, they can basically have, or they can refuse not to have. It's all in the tool. So we will basically make it in a way that it will look like as if its author is not around to do these sessions, or he's too busy or something like that. Able to generate revenue. So basically, this was another suggestion discussed, that probably the authors will have some revenue generated out of this. So when book is probably given to students, and then if they pay for it, then that particular revenue is shared with the authors. Though it is yet to be discussed with the, these are some of the work which we are conducting with the admin GLR team to have a final say on this. Features for readers and students. So basically they will have either a full access of these topics or limited access, or may have a free access for a short number of topics. And all these levels of access are granted by the admin, and they can basically secure a complete access if admin allows. Student can view videos and view topics, and able to comment and read those comments, and request one-on-one sessions. And these topics, when students read or review, then admin basically can give them assessments over these. So student basically can like get a review of their performances on these topics. Like we can send them small exams or tests to practice. We can give them that if there is a text base, if they can read and they can basically, we have a jumble up view so they can guess what is it, or there can be gamification in it to better learn those topics. And even like video based, we call the interactive videos, where they were, when they are watching some video of the procedure, they can have like how to do it in between those videos. So if they have watched 5 minutes of video, then there can be a session of how to do this, the 5 minute whatever the student has watched, how to do that video can be interactively created in those videos. So this is what we have sort of developed, and let me take you through the look of it. So this is the book. So digital book for laparoscopy, and though it is under development, we have not fully completed it. So these are this is like a trainer which we will build, which will train the students how to do the surgeries or how to surgery. And then there are approaches, and so like these are how they can review through this. So this will be generally available portal for them, and then if they will register, they will basically get started, register to the book, and they will enter, and this is basically working now. So the authors can register themselves, depending on Mr. Imran and GLR team opens it up. Once they register, the admin will basically able to, like, let me show you, this is a student view. So admin will basically activate the registration of students. So when a student basically looks at the book, they can view a topic. Okay, so I have logged out of it. Please, so let me try to re-log in. So, but it's like at the initial stages of development, and that's all from me. I think yes, it will take a little bit of time. So over to you, Dr. Imran.
Yeah, please. Thank you, Mubashir. So you can stop sharing.
Okay.
Yeah, you can stop sharing, I think.
Yep.
It's good. Thank you, really, Mubashir. It was great. So what is the idea? So idea is because I was thinking about since 2013. So we have just when we asked, so Laurent asked, this is my technique. Professor Rutledge always asks, this is my technique. Carbajo asks, this is my technique. So definite, Helmut Billy will ask, this is my. So we want your support. So this will be tips and tricks in bariatric surgery. So when tips and only tips and tricks, we don't go for detail. So then Laurent will have a short video of his technique. This is technique of primary. This is technique for redo. This is technique every. He can upload 20 types of surgeries, his experience. He will has access directly. Helmut will has access. Yes, this is my technique. How I evaluate this blood supply to this gastrojejunostomy. So then this will be for our youngsters, and this will remain. And also you will be able to upload these videos, these pictures from your home. There is no issue. Just you will have access, and then just you can imagine what will happen. And then we will have such a storage of knowledge and of such a legends, such an experience of legends. So it will be much easier for youngster to know if he want to know. So this, what is the so technique of Professor Robert Rutledge in redo surgery? No issue. He will click. Okay, this is the technique of Robert Rutledge. This is Laurent Layani. This is Helmut Billy. All over the world. So it's thanks Mubashir, and really, and we appreciate and hope soon we will be able to upload our videos.
Thank you. Yeah, any questions, any suggestions are most welcome.
Thank you. We will stay in touch. Thank you, Mubashir.
Thank
Thanks
you
a lot.
so much.
So, sir, because now really we are already little late. So, Professor Robert Rutledge, sir, it is great honor, really, because you have started this. You are real legend, and I think Professor is in field because he is not only surgeon, he is also athlete. So, sir, closing comment. Over to you, sir, please.
Great. I'd like to comment and say what you have done here is spectacular, and it deals with my feeling of the worst problem with MGB, OAGB, which is we have many good surgeons with slightly different ideas. So let us not criticize one another. Let us not say one is better than the other. Let us just make sure when we publish, we have a different naming system. So we say, this is MGB, but it has a dissection and repair of hiatus hernia. Or this is OAGB, but it has a different bowel length. What we want to do is not be critical of one another, but we want to learn from one another. So if we see that one surgeon has a low rate of marginal ulcers, instead of criticizing him and saying he is reporting badly or he doesn't do good follow-up, we say, you know, he's doing something different. And I go back to a recent paper which got my attention. It said in Australia, the MGB has a 10% failure rate, requiring a revision to Roux-en-Y gastric bypass. I think many of us on this meeting would not see anything like that. We don't think that they are presenting a false report. And I think our groups on this meeting are not presenting false reports. My suspicion is in the pre, intra, or post-operative period, there is something all of us can learn. And your suggestions of having the different versions is good. And maybe it's even a good idea not to use the name, but just to get a naming system to say this includes patients who have reflux pre-op, and we did or did not attack the EG junction, and we have a high protein diet post-op or otherwise. So what you have done, I think, is very, very important, very valuable. It's my honor for you to lead this, and I congratulate you on all your good work, sir.
Sir, thank you, sir. Sir, this all is due to you and all the team, because unfortunately we had short of time. You can't believe, because when I proceed all of these interviews, one of my question was when and why you have started this MGB. So Robert Rutledge was here. Robert Rutledge in our OT. So definite, sir. So if we see this all is your hard work, and now because when we are sitting from all over the world, and now MGB is going to popular. So this is due to you.
Sir, you're too kind. Again, though, we have faced these challenges and MGB is growing, but as we see today with your hard work, there are still areas of disagreement, not because any one of us is doing it badly, but because we are trying to learn. And we are all good men and women. We're all doing the right things. We need to learn and polish our technique and make it even better.
Sir, really thanks, sir. Sir, thank you. And this is your greatness, sir. Your greatness. And we need your guidance. We need your support. And hope with your support and guidance and with support of all of you, we will be able to also complete this ebook. So this ebook will help us in future. So you can upload your technique, you can anything. So it depends on you. What is your technique? So then youngsters will have so easy access, because the main issue is to learn tips and tricks. So this is very important. So hopefully with your support, yes, we will be able to standardize this GLR ebook, and in future, so it will be also a little contribution for sharing knowledge of such a great and legends. Thanks, sir. Thanks a lot, sir.
Thank you, sir.
Sir, so much thanks. So this is the time to close. And again, I ask, so it is a great honor for us. So thanks all of you for your time. Again, we are a little bit late, but have a nice time. And again, we will continue our this sharing of knowledge in series of sleeve gastrectomy. So there are also many legends who are doing sleeve gastrectomy, and we will continue this series for 6 months already. So we have confirmed these persons, these legends, and we need your support, your guidance, and also viewers. So much thanks till this time. Your follow-up. If you have again any question, you can add your questions in comments, and all of these legends will be available and they will answer your question. So thanks, sir. Thank you, sir.
Thank you.
Thank you, sir.
Thank you very much. Thank you. Have a nice evening.
Thank you, sir.
Good to see you all.
Thank you, Imran.
Thank you, sir.
Good to see you, Imran, Carl, Lauren, Kular, Enrique.
See you soon, I hope.
Yep. See you.
Shanghai, the most progressive city in China, a global center for cutting-edge science and technology. In 2011, Easy Circ Medical was born here. Technical innovation has ensured Easy Circ's leading position in promoting new techniques from minimal invasive surgery. Our R&D team is committed to exploring better solutions, creating clinical value, focusing on details, and ensuring very high quality. Every time a key obstacle is overcome, we realized a breakthrough in minimal invasive surgery medical device. In Shanghai and Suzhou, Easy Circ's 2 large production facilities are beginning to take shape. Clearance at GMP 100,000 degree, automated production lines, and a system for lean manufacturing, and efficient quality management system have laid the cornerstone for the outstanding quality. High-quality surgical devices, surgical equipment. We have created our very own self-reliant premium brand to ensure that innovation never stops. Easy Circ has created its own unique knowledge database model for product design. Through in-depth discussion with clinical professionals, we have explored new directions in medical technology and devised ingenious solutions in collaboration with a host of engineers and technical experts. Together, we have created valuable innovations that are leading the way in minimally invasive surgical techniques, and we continue to promote their development in order to ensure patients' quality of life post-surgery. Easy Circ is vying for success in the market for exclusive medical devices. The company has already been recognized as a National High-Tech Enterprise, a Brand Cultivation Showcase and Prize by MIIT, and the Shanghai Brand Cultivation Showcase and Prize, and the Specialist Enterprise in Shanghai. Easy Circ Medical holds numerous patents. A heart of virtue. We are striving to achieve our goal of providing patients with affordable, high-quality, minimally invasive surgical devices. Easy Circ Medical will continue its work in technical innovation and industrialization of premium medical devices. the seeding and creation of Shanghai Center of Technical Innovation, and creating a respectable, exclusive brand for global minimally invasive surgical products. We aim to be an influential participant in the international market and to help surgeons and patients throughout the world.